Good morning, ma'am. Good morning, all.
Good morning, Dr. Sonia.
So warm good afternoon to all of you, and we'll be shortly starting a session. Let us wait for another 5 minutes to for other participants to join, and then we would be starting our session. Meanwhile, a warm welcome to all the delegates, and just wanted to know what was the Dr. Sindhu, could someone tell me what was the number of delegates we had yesterday, so that we can decide, can we go ahead or should we wait for some time?
It was 300 plus, Dr. Sonia. So I think we should wait for 5 minutes.
Definitely, ma'am. We'll wait for
Then
some
we'll
time.
start.
Yes. So we are now 206. Ma'am, shall we start now?
Yes, I welcome all the participants to this day 2 of the training program on COVID-19 management in children. And today, Dr. Sonia Bhatt and Dr. Sarika Gupta will moderate the session. Dr. Sonia Bhatt is from FH Medical College, Firozabad, and she is also our first speaker. And she will be talking about the oxygen therapy in children. And we all know the importance of oxygen therapy in children with COVID-19. So let's start, Dr. Sonia.
Good morning, good afternoon, and a warm welcome to all the delegates. And at the outset, many thanks to the organizers and the faculty who has contributed to this wonderful module, which is helping all of us to be skilled in pediatric COVID-19. As we all know that anticipated third wave, we all are anticipating that it may take a little more brunt on the pediatric patients, and this is our effort to train all of our esteemed delegates also, so that we don't have problems as we faced in the first and second wave. So this is the day 2 of our training. As you all know, yesterday you would have been well versed with the introduction to the COVID-19, what are the clinical presentations, and a little about the management at level 2. So we know COVID has already affected more than 3 crore of the Indian population. More than 4.5 lakh deaths have been recorded. And when we talk of management of COVID-19, we have to keep in mind that the patients or the children who require our care and whom we are targeting at is the patients who would be presenting to us with moderate, severe or critical COVID, because that is the place where we have to intervene early, and we have to prevent the morbidities and mortality, because most of the mild cases are well managed at home and do not require any intervention. So today, whatever we talk, it is pertaining not only to pediatric COVID, it has the basics of, it will be related to your basic physiology, oxygen therapy, advanced NIV, that is the non-invasive ventilation. Then we'll be talking about your arterial blood gas analysis, and we'll be covering almost five topics today. And they will also have knowledge about adult COVID also. So so the presentations are so that they'll help you in both management of both adult and pediatric COVID. Yes, we'll talk a little more about the pediatric COVID. So now I'll start my presentation. So before, so ma'am already introduced that I would be taking about oxygen therapy indications and the oxygen delivery systems. After that, we have Dr. Rajesh Kumar Meena, Associate Professor from IMS BHU, who would be teaching about non-invasive ventilation, use of BiPAP, CPAP, and HFNC. And after that, we'll have a session on enlightening session on ABG by Dr. Sarika. And then we have 2 more lectures, discharge policies on post-COVID care by Dr. Saksham Srivastava, Professor Integral Medical College, and handling of disease by Dr. Anupama Verma from LLRM Meerut. So, ma'am, is my screen seen? My screen is seen, right?
Yes, your screen is visible.
So, so I would be talking basically about oxygen therapy and delivery, a little about the respiratory physiology, and briefly I would be touching on the non-invasive modes of ventilation, which would be covered in detail in the next session. So the learning goals are that this presentation will help you improve your knowledge, skill, and clinical practice in the oxygen usage. And also we have to learn the optimization of use of oxygen, as we all know that oxygen is a very important drug, and misuse and overuse have its harmful effect. And we'll know a little about what is hypoxia in COVID-19, which would be covered later in this lecture. After that, how to assess respiratory distress. So I would be talking about few terms which will be used again and again in this presentation and in the subsequent presentation, and even when you go for ventilation. So there's one word called PaO2. So this PaO2 means the partial pressure of oxygen in the inspired air. जिसको कि हम लोग यूजुअली जब एबीजी होता है, इन्वेजिव मोड ऑफ वेंटिलेशन, जब हम इन्वेजिव मॉनिटरिंग करते हैं, एबीजी में जो आपको मिलेगा देखने को PaO2, A इज आर्टीरियल ब्लड। उसके बाद एक टर्म है SaO2, SaO2 इज saturation, the saturation of hemoglobin, जो ऑक्सीजन which is bound to hemoglobin in arterial blood, जिसको कि it is known as SaO2, and both PaO2 and SaO2 are two things which we will see in ABG, but ABG is not possible everywhere. इसलिए there's another term which is used, SpO2, which we all are well versed, even the common person, lay person is well versed. This is when the same SaO2 is seen non-invasively by a pulse oximeter, we call it SpO2. So these terms would be used a lot. Then there's one thing, FiO2, जिसको भी समझना जरूर। FiO2 is the fraction of oxygen in inhaled air. So whatever air we are inhaling, what is the percentage of oxygen in that air? Suppose all of us are getting a FiO2, we know that this air has 21% oxygen. So our FiO2, what we are inhaling now is 21%, or we call it 0.21. So as we increase oxygen supply and use different delivery system, this FiO2 is what we target to increase. और इसी से ड्रग डिलीवरी सिस्टम भी डिसाइड होता है कि कौन सा डिलीवरी सिस्टम कितना ऑक्सीजन ज्यादा दे सकता है. सो दिस इज द फ्रैक्शन ऑफ ऑक्सीजन इन इनहेल्ड एयर. दिस विल बी यूज्ड. अपार्ट फ्रॉम दैट, अ वेरी इंपॉर्टेंट टर्म इज मिनट वेंटिलेशन. मिनट वेंटिलेशन का क्या इंपॉर्टेंस है? मिनट वेंटिलेशन, सपोज इफ आई से व्हाट इज माय रेस्पिरेटरी रेट, if I am taking 20 respiration in a minute, that is my respiratory rate. So that is RR. Then with each respiration, how much air I take is known as tidal volume. Or minute ventilation is the multiplication of respiratory rate into tidal volume. So this, why minute ventilation is important? Because whenever we are in the state of disease or in the disease state of health, we are trying to maintain our minute ventilation. So minute ventilation is the total amount of air which is inhaled or exhaled in a single minute. Respiratory rate आपको पता है कि पेशेंट का अगर 20 है, अगर उसका tidal volume 500 है, तो MV will be 1000. So please keep these terms in mind. Then we'll be discussing about the indication and goal of oxygen therapy. We'll be reading about the oxygen delivery system, and we'll be seeing few videos also. So let us start with a very interesting case, because when we discuss a case, the things will be more clear to you. So this is a 5-year-old Ram presenting with fever, cough, difficulty in breathing. On examination, child has tachypnea, respiratory rate is 46, chest indrawing is there, child is irritable, pale, and SpO2 is 90%. Systemic examination is normal except bilateral clefts. So what will be the initial impression? कल आप लोगों को जब बताया गया होगा this how to evaluate a sick child, we always remember that हम किसी भी patient को देखते हैं तो we see the A, B, C. So what is the appearance of the child, what is the breathing of the child, and what is the constitution of the child. We see appearance is not comfortable, this child is irritable. B, breathing, respiratory rate आप लोग देखिए कितना है, 46. तो यहाँ पे आपको क्या याद रखना है, adults में हम लोग को पता है कि 16, 18, 24 is the limit where we take, but बच्चों में less than 2 months, more than 60 is the known as tachypnea. 2 महीने से 1 साल तक अगर 50 से ज्यादा रेस्पिरेटरी रेट हो तो उसे tachypnea कहते हैं. 1 to 5 years, more than 40 is tachypnea, more than 5 years, more than 30. So now we know कि respiratory, जब हमने breathing देखा तो breathing में भी क्या है, respiratory rate is fast. Apart from that, breathing में और हमें क्या देखना है, rate देखा, हमने देखा chest indrawing, so accessory muscles are working, ठीक है. Then we see that adventitious sounds, clefts are present. जब भी clefts present होती है तो we know that the lung parenchyma is involved. तो यहाँ से हमें क्या पता चल रहा है कि severity of the illness पता चल रहा है कि respiratory rate is high, chest indrawing is there, SpO2 is 90, which falls between at severe COVID. And we know that our aim is to maintain more than 94%. Then 90 to 94 is moderate. So with this initial impression only, we know that we are dealing with a case of respiratory distress, which is going to impending respiratory failure. So first thing is always have an initial impression, and always with this initial impression, first thing is evaluate the child, which we have done, and then we have to identify the severity, which we have identified, that is a severe respiratory distress, which is going to impending respiratory failure, and you have to accordingly intervene. So always remember this: evaluate, identify, intervene. This cycle goes on at each step when we are managing a case. and then we have to make a treatment plan, and monitoring has to go side by side. Monitoring has to be clinical, monitoring has to be non-invasive, monitoring has to be invasive also. So case, we already discussed that this child has some respiratory problem with presence of emergency signs. Severity, is it distress or failure? So because we know that this child has all the signs, so this child has hypoxic respiratory failure, or we may also call it impending respiratory failure. What is the difference between respiratory distress and respiratory failure? So whenever a patient is trying to compensate with his efforts, increasing his tidal volume, increasing his depth of respiration, तो क्या कहते हैं उसको हम respiratory distress. लेकिन at one stage अगर हम intervene नहीं करेंगे तो यही respiratory distress respiratory failure में change हो जाता है. जैसे कि अगर patient tachypnea से, tachycardia से, increased respiratory rate से, increased chest expansion से present कर रहा है तो वो क्या है, distress है. लेकिन जैसे जैसे ये आगे बढ़ेगा तो क्या हो जाएगा, patient में land up into respiratory failure. उसमें क्या हो जाएगा, bradycardia, bradypnea, poor respiratory efforts, apnea. Even if you are doing an ABG तो आपको PCO2 बड़ी भी मिलेगी, more than 60, pH will fall more than 7.2. So this is how you differentiate between distress and failure. So our treatment plan will be, first thing, we want to maintain the saturation. तो उसके लिए सबसे पहले हम क्या करेंगे, vital signs देखेंगे, symptomatic management देखेंगे, airway open है कि नहीं देखेंगे. If airway is not open तो क्या करेंगे, gentle suction करेंगे. If this child is cannot open, cannot maintain the airway, अगर आपको airway चाहिए तो secure the airways, and then we start the oxygen supplementation. तो सबसे important, अब हमने decide तो कर लिया oxygen supplementation देना है, but always use oxygen as a drug, क्योंकि as oxygen is beneficial, we know that it is also harmful. So an undue wastage of oxygen should not be there. Monitoring, again I told, has to be 3-way. सबसे important है आपका work of breathing देखना. Then if you don't have a ABG facility, and if you want, because now we know pulse oximetry is also known as fifth vital sign. Pulse oximetry से आप saturation देखेंगे, and to have a more objective view कि इस बच्चे को oxygen ही sufficient है, कि हमें उस बच्चे को high flow oxygen देनी है, or the patient requires non-invasive mode of ventilation, we have to be ready with a ABG. So this slide shows कि prescription, जैसे हम drugs की prescription लिखते हैं, जैसे हम लोग ceftriaxone का, जैसे हम IV fluid का prescription लिखते हैं, in the same way when you are writing a prescription, please don't forget to mention that oxygen therapy किस तरह से आप दे रहे हैं, which device you are using, whether you are using a prong, whether you are using a mask, simple face mask, or you are using a non-rebreathing mask, ये सब आपको लिखना है, किस flow पे आप दे रहे हैं, what is your target, everything has to be written in detail. So this child, so how do you assess respiratory distress? Clinically, आपको बहुत बार बताया कि symptom and work of breathing are important, SpO2 is important. You also have to see the hemodynamic stability of the patient, क्योंकि whatever oxygen you take, which body part has the power, कौन सा body part deliver कर रहा है, so आपका delivery का काम किसका है, heart का है. Okay, so the oxygen delivery, so if you are not hemodynamically stable, that's why there are certain conditions, जैसे कि you don't give oxygen only if a patient has respiratory distress. हम कब देते हैं, we have to give respiratory distress if a child has is congestive cardiac failure, if a child has severe anemia, if a child is actively seizing, तो ये सब conditions में भी हमें oxygen देना होता है, because though the oxygen is taken by the upper airway, conducting airways and lungs, but once it goes to your bloodstream or capillaries, the heart has the function to deliver it to the different tissues. Then आपको ABG करना है, SpO2 monitoring करनी है. ABG में हम क्या देखेंगे, आपको बताया था, partial pressure of oxygen is very important. FiO2 तो हम लोग जो दे रहे हैं वो हम लोग डिटरमाइन करेंगे कि हमने कौन सा डिवाइस. एंड देन देयर इज अ वेरी इंपॉर्टेंट PF रेशियो, दैट इज PaO2 और FiO2. PaO2 आप कहाँ से देख रहे हैं, ABG से. FiO2 आप कहाँ से देख रहे हैं, आप कितना ऑक्सीजन दे रहे हैं वो आपको पता है. सो दिस PF रेशियो एंड SF रेशियो, व्हाट इज द इंपॉर्टेंस, दे हेल्प यू टू टेल द डिग्री ऑफ respiratory distress and is a very important marker of ARDS. इसकी वैल्यूज होती है less than 300 is severe respiratory distress, less than 100 is severe ARDS. Now a little about pulse oximetry, which will be covered in detail in the multipara monitors also, which we have a separate lecture. So pulse oximetry we all know is a surrogate marker of SaO2. Okay, so pulse oximetry works on the principle कि आपकी जो different hemoglobins हैं, hemoglobin, oxygenated hemoglobin, deoxygenated hemoglobin, they absorb different wavelength of light एंड आपका जो पल्स ऑक्सीमीटर का जो आप मॉनिटर लगाते हैं, दैट हैज अ लाइट इमिटिंग डायोड और नीचे होता है फोटो डायोड, तो वो जो लाइट एब्जॉर्ब करता है, so this basically sees the ratio of whole hemoglobin to oxygenated hemoglobin. So this is also known as functional saturation. It is a very important tool, but it has its few limitations. आपको देखना है कि which position you are putting. You have to see that the child is not in shock, periphery is cold तो नहीं है, nail paint is not applied, or there is any artifact, हाथ पैर हिल तो नहीं रहे. These are the conditions where you may get a dubious reading, and you have to be careful. So these are the different type of SpO2 probes which are available. These small ones are usually used for neonates. This is what is used for adults. The usual site is fingers, toes, but you can also, this can also be used in earlobes also. So a little about, before we move to the details, आपको थोड़ा सा पता होना चाहिए about the oxygen dissociation curve. So what is the oxygen dissociation curve? This is a curve which shows the relation between the partial pressure of oxygen to the hemoglobin saturation. So we all know that oxygenated hemoglobin is SpO2 is कि आपकी जो hemoglobin से कितना oxygen bind है. So what happens usually when सबसे पहले deoxygenated hemoglobin कहाँ जाता है? Lungs पे जाता है. तो whenever the deoxygenated hemoglobin goes to the lungs, the oxygen will try to bind to the oxygenated hemoglobin. So whenever the oxygen tries to bind with the hemoglobin, initially ये bond जो होता है बहुत tight होता है. There are 4 hemoieties. Bond बहुत tight होता है, and oxygen cannot easily bind with the hemoglobin. The moment एक oxygen molecule bind होता है, this bond is released, and suddenly many oxygen molecules start binding to the hemoglobin molecule. So that's why you see this is not a linear curve, this is a sigmoid shaped curve. तो जैसे पहले initially मुश्किल होगा ऑक्सीजन को बाइंड करना, and slowly it starts binding, and here it takes a flat shape. So this shows कि एक बार ऑक्सीजन पूरा बाइंड हो जाए, whatever partial pressure of oxygen आप कितना भी बढ़ाएंगे, the saturation will not improve further. That's why, and the moment this PaO2 starts falling, you see this up to 100 to 90, the relation between this curve is very good. 100 में आपका 100 PaO2 है, 90 में it's around acceptable 60. But the moment your SpO2 shows less than 90, that means the partial pressure has fallen way below, and this is a dangerous condition. That's why आपने देखा होगा कि जो भी हमेशा आपके जो target रखे गए हैं to start O2 at 90%. So the correlation of this curve is good at up to 90%, but the moment it falls, SpO2 is being seen. अगर आपको SpO2 90% से कम दिख रही है, इसका मतलब partial pressure of oxygen has fallen much below. That is a dangerous condition. So indications क्या है ऑक्सीजन थेरेपी के? हमने फिर से बहुत बार डिस्कस किया कि अगर कोई बच्चे हेलो कैन hear some voices, can muted please. Yeah. So जो भी बच्चा emergency signs, अगर बच्चे के पास बच्चा has come with emergency signs, and then you can and if the emergency signs are in the form of increased respiratory rate, severe anemia, this cardiopulmonary shock, and if SpO2 is less than 90%, तो आपको ऑक्सीजन स्टार्ट कर देना है, क्योंकि हमारा एम क्या है? ऑक्सीजन देने का मेन एम है टिश्यू हाइपोक्सिया प्रिवेंट करना. सो देयर टू टर्म्स, हाइपोक्सीमिया और हाइपोक्सिया. इनका भी आपको डिफरेंस समझना है. हाइपोक्सीमिया इज when the partial pressure of oxygen is less in arterial blood, जो कि आप PaO2 अगर देखते हैं adults में 80 to 100 होता है normal, बच्चों में भी 80 to 100, neonates में 50 to 80 होता है. So when we see a ABG जिसमें कि PaO2 less होता है, that condition is called as hypoxemia. यही अगर टिश्यू में ठीक से ऑक्सीजन डिलीवरी नहीं हो रही है और वहां पे एरोबिक रेस्पिरेशन नहीं हो रहा, that condition is known as hypoxia. So what is our this goal? To maintain adequate tissue oxygenation, correct acute hypoxemia, decrease symptoms associated with hypoxemia, and decrease the cardiopulmonary workload. Now we'll just have this video which will show you the use of various oxygen therapies. Is the video seen?
मैं डॉक्टर राजेश मीना।
Video is seen and audible?
आज हम इमरजेंसी वार्ड और आईसीयू में ऑक्सीजन थेरेपी कैसे देते हैं, कौन कौन सी डिवाइसेस होती है, वो उन सब के बारे में जानकारी लेंगे। तो सबसे पहले हम जानकारी लेंगे फ्लो मीटर के बारे में। इसको बोलते हैं फ्लो मीटर। देखिए ये आपके जो है सेंट्रलाइज पैनल पे लगा होगा एक फ्लो मीटर। इसमें
One video is not being played actually, it's only the audio which is visible. The video is not being played.
Not being played?
Yes, it's not running, only the audio is being visible. Audio is being audible. That's it.
Video is not being played. Okay, 1 second.
Can you replay it, ma'am?
I'll do it because here it's playing.
मैं डॉक्टर राजेश मीना। आज हम इमरजेंसी वार्ड और आईसीयू में ऑक्सीजन थेरेपी कैसे देते हैं, कौन कौन सी डिवाइसेस होती है, वो उन सब के बारे में जानकारी लेंगे। तो सबसे पहले हम जानकारी
And still there is an issue. I'll play the video from my end.
Okay. Then I'll stop.
Yes.
इसमें ये बॉबिन होता है, ये आपका कंटेनर है। इसमें आपको डिस्टिल वाटर भरना है। इसमें लोअर लेवल है और एक अपर लेवल, ये दो लेवल आपको दिख रहे होंगे। आपका जो है लोअर लेवल इतना, इससे नीचे जो है पानी, अगर इससे कम है
Ma'am, please stop the video.
अपर लेवल से ऊपर भी नहीं जाना है। और ये है आपके बॉबिन। आपको फ्लो यहाँ से बस इसको नॉब को घुमाते हुए फ्लोज सेट कर सकते हैं। आप देख रहे हैं कि नॉबिन धीरे धीरे ऊपर जा रहा है। 2 लीटर।
मैम अभी भी आ रहा है। Yeah, now it is gone. Yeah.
मैं डॉक्टर राजेश मीना। आज हम इमरजेंसी वार्ड और आईसीयू में ऑक्सीजन थेरेपी कैसे देते हैं, कौन कौन सी डिवाइसेस होती है, वो उन सब के बारे में जानकारी लेंगे। तो सबसे पहले हम जानकारी लेंगे फ्लो मीटर के बारे में। इसको बोलते हैं फ्लो मीटर। देखिए ये आपके जो है सेंट्रलाइज पैनल पे लगा होगा एक फ्लो मीटर। इसमें ये बॉबिन होता है, ये आपका वो है कंटेनर है। इसमें आपको डिस्टिल वाटर भरना है। इसमें लोअर लेवल है और एक अपर लेवल, ये 2 लेवल आपको दिख रहे होंगे। आपका जो है लोअर लेवल इतना, इससे नीचे जो है पानी, अगर इससे कम है तो आपको वापस फिल करना है। अपर लेवल से ऊपर भी नहीं जाना है। और ये है आपके बॉबिन। आपको फ्लो यहाँ से बस इसको नॉब को घुमाते हुए फ्लोज सेट कर सकते हैं। आप देख रहे हैं कि नॉबिन धीरे धीरे ऊपर जा रहा है। 2 लीटर, 3 लीटर, 7 लीटर, 5 लीटर और मैक्सिमम इसमें आप 15 लीटर तक ऑक्सीजन दे सकते हैं। अब इसके बाद आता है डिवाइसेस। सबसे पहली डिवाइस है नेजल प्रॉम्प्ट, या कुछ लोग इसको नेजल कैनुला भी बोलते हैं। तो ये एडल्ट नेजल कैनुला है। इसको आपको कैसे लगाना है? इसके 2 एंड है, ये पेशेंट एंड है और ये फ्लो मीटर एंड है। फ्लो मीटर एंड को आपको इसमें जाके कनेक्ट करना है, इसके एग्जिट पॉइंट पे, और इसको फिक्स कर देना है। उसके बाद ये दूसरा जो है एंड, आपको पेशेंट के पास जाना है, उसको बताना है कि अब आपको ऑक्सीजन दे रहे हैं, और ये दोनों नॉस्ट्रल्स में जाके फिट करना है। इसके बाद इसको पीछे से टाइट कर देना है। ये आप देख रहे हैं, ये पीछे से टाइट कर देना है, जिससे कि ये आपका प्रोंक्स स्नगली फिटेड हो। ठीक है, ये हो गया हमारा नेजल कैनुला। अब इसके बारे में हम थोड़ी जानकारी लेते हैं कि इसको कब यूज़ करना है आपको। इसको आपको जो है, आपका कोई पेशेंट या तो ऑक्सीजन थेरेपी से जब वीन कर रहे हो, या इनिशियली माइल्ड टू मॉडरेट केसेस में यूज़ करना है, जहाँ पे आपके पेशेंट की ऑक्सीजन रिक्वायरमेंट मीन्स FiO2 रिक्वायरमेंट जो है 45% के आसपास हो। तो इसमें आपको कितना फ्लो सेट करना है? इसमें आप 1 लीटर से लेके और 6 लीटर तक का फ्लो देना है। मैक्सिमम 6 लीटर का फ्लो देना है। 6 लीटर से के ऊपर से फ्लो इसमें नहीं देना है। ये हो गया आपका नेजल कैनुला और नेजल प्रॉम्प्ट। इसके बाद आता है आपका, जिसको हम लोग बोलते हैं सिंपल फेस मास्क और ऑक्सीजन मास्क। ये आपको कब यूज़ करना है? जब आपके पेशेंट की ऑक्सीजन रिक्वायरमेंट और FiO2 रिक्वायरमेंट जो है 60% के आसपास हो। उस केसेस में आपको फेस मास्क या ऑक्सीजन मास्क लगाना है। इसमें भी सिंपल है, इसके भी 2 एंड है। ये आपका पेशेंट एंड हो गया, ये आपका फ्लो मीटर एंड हो गया। इसको भी फ्लो मीटर पे इसी एग्जिट एंड पे कनेक्ट करना है और ये अपने जो है पेशेंट को, ये एंट्री पॉइंट नीचे रहेगा, ये इलास्टिक है, उसको जो है ऐसे इसके ऊपर से और ये लगा देना है इस तरीके से फिट। अगर आपकी बहुत लूजिंग है तो ये स्ट्रैप से इसको थोड़ा टाइट कर सकते हैं, ये स्ट्रैप्स है, इसके स्ट्रैप्स के थ्रू इसको टाइट कर सकते हैं। इसके बाद तीसरी डिवाइस जो है, जो आज हम डिस्कस करेंगे, वो है नॉन रीब्रीथिंग मास्क। ये आप देख रहे हैं, ये है नॉन रीब्रीथिंग रिजर्वायर बैग। ये रिजर्वायर बैग है, ये आपका सिंपल फेस मास्क है। अब इसको किस पेशेंट में यूज़ करना है आपको? जिस पेशेंट की रिक्वायरमेंट FiO2 रिक्वायरमेंट अराउंड 90 to 100% है, उसमें FiO2 रिक्वायरमेंट उन सब पेशेंट्स में यूज़ करना है। मोस्टली ICU पेशेंट्स जो सीवियर डिजीज़ के पेशेंट हैं, उसमें आपको ये नॉन रीब्रीथिंग फेस मास्क यूज़ करना है। इसके भी 2 पॉइंट हैं, ये आपका पेशेंट एंड हो गया, ये आपका फ्लो मीटर एंड हो गया। सिंपली इसको भी जो है फ्लो मीटर से अटैच करना है और पेशेंट पे जो है इसको सेम ऐसे ही आप लगा सकते हैं और स्ट्रैप के साथ टाइट करना है, इस स्ट्रैप के साथ ऐसे, और उसके बाद आपको यहाँ से फ्लो जो है ऑन कर सकते हैं। अब इसकी जो इसमें जो है आपको 10 लीटर के फ्लो से शुरू करना है। इसमें आप ये नहीं कि 2 लीटर 3 लीटर के फ्लो में छोड़ दिया, इसको मिनिमम 10 लीटर के फ्लो से शुरू करना है और मैक्सिमम जो है आप 15 लीटर के फ्लो पे जा सकते हैं, उससे ज़्यादा नहीं जाना है। तो उसमें मतलब 15 लीटर के फ्लो में आप कम से कम 95% FiO2 अचीव कर पाएंगे। आप देख रहे हैं ये आपका जो है ऑक्सीजन जा रही है, वेपर्स बन रहे हैं और बैग फिल हो रहा है। तो ये पूरा कंप्लीट बैग जो है फिल होना चाहिए। स्टॉप करें।
Am I audible? My screen is seen.
Yes.
Yeah, okay. So now we saw different type of oxygen delivery systems. ऑक्सीजन डिलीवरी सिस्टम्स क्या सिस्टम्स होते हैं जो कि एक डेफिनेट O2 का फ्लो रेट जो हम बोलते हैं कि कितना हम पर मिनट फ्लो दे रहे हैं और कितना FiO2 दे रहे हैं, उस हिसाब से जो ऑक्सीजन डिलीवरी सिस्टम होते हैं वो 2 तरह से डिवाइडेड होते हैं। वन इज हाई फ्लो नेजल ऑक्सीजन सिस्टम एंड वन इज लो फ्लो सिस्टम्स. So low flow systems or variable performance system are the systems in which we do give oxygen, but we cannot decide how much FiO2 and rate depends on the respiratory rate, the efforts of the patient. तो जो जैसे कि हमने अभी डिस्कस किया था कि आपका जो नेजल प्रॉन्ग्स हैं या फिर आपका फेस मास्क है, ये सब जो डिवाइसेस होती हैं इनको हम बोलते हैं वेरिएबल परफॉर्मेंस या लो फ्लो सिस्टम्स, बिकॉज इसमें हमें ये एग्जैक्ट डिसाइड नहीं हो पाता कि FiO2, though we give high flow but high FiO2, but is the patient able to accept? We don't know. But there are certain other systems in which we are able to fix the FiO2 and where we are very sure that जो FiO2 हम पेशेंट को दे रहे हैं वही डिलीवर हो रहा है, उसको बोला जाता है फिक्स परफॉर्मेंस या हाई फ्लो सिस्टम. इन हाई फ्लो सिस्टम्स में क्या क्या डिवाइसेस आती हैं वो हम आप लोग को बताएंगे. उसके बाद देयर इज अ हाई फ्लो नेजल ऑक्सीजन सिस्टम व्हिच इज आल्सो नोन एज HHHFNC, जिसको कि हीटेड ह्यूमिडिफाइड हाई फ्लो नेजल ऑक्सीजन सिस्टम भी बोलते हैं. And then before intubation there are certain systems which we can use in a patient to help in the respiratory support. Those are known as non-invasive ventilation. So variable performance system, जैसे मैंने आपको बताया, it is insufficient to meet the patient's peak inspiratory and minute ventilatory requirements. We already discussed कि जब भी हम patient को support कर रहे होते हैं या हम respiration ले रहे होते हैं, हमारा aim है कि जो minute ventilation है, respiratory rate into tidal volume, वो हमारा meet होना चाहिए. Patient का या जो patient in distress है, उसका meet होना चाहिए. तो ऐसा delivery system जो कि जिसका कि हमें कंफर्म नहीं है कि वो मीट हो रहा है कि नहीं, दोज आर नोन एज वेरिएबल, क्योंकि वी डोंट नो, इट्स नॉट फिक्स. सो दिस इज इट प्रोवाइड, अगर पेशेंट का रेस्पिरेटरी एफर्ट अच्छा है, अगर पेशेंट कॉन्शियस है, तो दे प्रोवाइड रिलेटिवली स्टेबल FiO2 एज लॉन्ग एज द रेस्पिरेटरी रेट एंड पैटर्न आर स्टेबल. कैन डिलीवर हाई FiO2 बट एक्चुअल अमाउंट विल वेरी फ्रॉम ब्रेथ टू ब्रेथ. तो इसके एग्जांपल्स हैं नेजल प्रॉन्ग्स, कैन्युलास, सिंपल फेस मास्क, इवन ये HFNC सिस्टम जो कि 90 जो अभी हमने डिस्कस किया था कि 90 to 95% FiO2 दे सकता है, बट वही हर ब्रेथ के साथ पेशेंट के रेस्पिरेटरी एफर्ट के साथ इसका FiO2 चेंज हो सकता है. देन क्विकली मैंने आप लोग को मिनट वेंटिलेशन के बारे में बार बार बताया था, ये इंपॉर्टेंट क्यों है. मिनट वेंटिलेशन इज रेस्पिरेटरी रेट इनटू टाइडल वॉल्यूम, ये डिस्कस किया था. अब हम लोग देखते हैं कि अगर मिनट वेंटिलेशन एक पेशेंट नॉन रेस्पिरेटरी डिस्ट्रेस का है, मतलब नॉर्मल जैसे हम रेस्पिरेशन ले रहे हैं, एक है रेस्पिरेटरी डिस्ट्रेस का, तो पेशेंट जो नॉन रेस्पिरेटरी डिस्ट्रेस का है, सपोज वी से कि हिज रेस्पिरेटरी रेट इज 10, वी डिस्कस दैट इट इज मिनट वेंटिलेशन इज रेस्पिरेटरी रेट इनटू टाइडल वॉल्यूम. सो टाइडल वॉल्यूम अडल्ट का 500 इंटू 10, तो उसका मिनट वेंटिलेशन कितना हुआ, 5 लीटर पर मिनट. पेशेंट डिस्ट्रेस में है तो उसका रेट एकदम से बढ़ गया, रेट इज रेस्पिरेटरी रेट इज 40 and this tidal volume remains the same, so his respiratory rate minute volume is 20. O2 हमने दोनों को एक ही, हमने we didn't see कि क्या ये physiology है, we gave 2 liter per minute to both the patients. अब आप देखिए जहाँ पे non respiratory distress का patient है, उसका अगर हम मानते हैं minute volume is 5.
Ma'am, sorry to interrupt you, but your slides are not showing.
Not showing. Someone told it's visible actually.
No, ma'am, slides are not visible. Your screen is visible.
Okay. I asked someone, they told it's visible. Okay, 1 second, give me a second. One second. Is it seen now?
Now.
Okay,
yes.
Okay, fine. Thank you. Yeah. So हम लोग ये डिस्कस कर रहे थे कि मिनट वेंटिलेशन का क्या इंपॉर्टेंस है. रेस्पिरेटरी, अब अगर हम ये जो पेशेंट डिस्ट्रेस में नहीं है उसका देखें तो हम उसको ऑक्सीजन कितना दे रहे हैं, 2 liters per minute. तो what is being happening कि 2 liter per minute तो हम सपोर्ट कर रहे हैं, which is receiving 100% ऑक्सीजन. 3 liter per minute के लिए हमको खुद मेहनत करनी पड़ रही है. सो एयर हम अगर environment से ले रहे हैं, it is 21%. So it becomes 0.21. So when we calculate, this is the flow rate divided by your minute ventilation. So FiO2 का formula होता है whatever oxygen is being received by the patient divided by minute ventilation. तो इसका minute ventilation 5 था, 1 into 2 plus, तो इसको हमारा FiO2 सेम जो हम ऑक्सीजन दे रहे हैं, FiO2 कितना डिलीवर हो रहा है, 53%. अब इधर हम देखते हैं 2 liter per minute हमने दिया, 20 लीटर हमें मेंटेन करना है. So 18 liter per minute is being taken from the environment. So what is happening? 100% 2 liter मिल रहा है, लेकिन जो 18 liter वो हम कोशिश करके कहाँ से ले रहे हैं, environment से, that is 0.21 divided by our minute ventilation is 20, which comes to 0.28. So the purpose of showing is that in the different respiratory pathologies, same flow will give you a different FiO2. अगर बिना डिस्ट्रेस का पेशेंट है तो वही ऑक्सीजन कितना दे रहा है, 53% FiO2. डिस्ट्रेस वाला पेशेंट है तो 0.3. So we have to keep this in mind that more the patient is sick will require higher flow rates. Fixed performance system आप लोग को हमने बताया. These systems give a fixed FiO2, give a fixed pressure, and these are known as high flow systems or fixed performance system. The examples are HFNC, BiPAP, CPAP, which will be discussing today, and ventilators. We all know वो तो होते ही हैं, तो that will be discussed tomorrow. Selection, how to select a device. Already आपको videos में अच्छे से बताया गया है. So it depends on the age, how big is the child, what is the oxygen requirement, humidification चाहिए कि नहीं चाहिए. Humidification is mostly required in all the cases unless and until the flow is very low. Patient's comfort, clinical status of the patient, and we have to use economically. ह्यूमिडिफिकेशन हमेशा जरूरी होता है। वी नो कि हमारा जो अपर रेस्पिरेटरी ट्रैक्ट है उसका वर्क ही ह्यूमिडिफाई करना, हीट करना, फिल्टर करना। बट व्हेनेवर वी आर यूजिंग हाई फ्लो ऑक्सीजन थेरेपीज द अपर एयरवे गेट्स बाईपास। इसकी वजह से क्या होता है, ह्यूमिडिफिकेशन नहीं होता, लॉट ऑफ क्रस्टिंग इज देयर, secretions become thick, and there is lot of bronchoconstriction also. So whenever you are giving oxygen at high flow, maybe more than 2 liters per minute in children under 2 years of age, 4 liters per minute in children over 2 years of age, and more than 1 liter per minute in newborns, always you have to give humidified oxygen. So nasal prongs, we have talked in detail that these are available in different sizes. 1 से 6 लीटर पर मिनट तक का हम लोग इसका रेट दे सकते हैं। ये एक न्यूनेटल प्रॉन्ग है। इसी तरह से अडल्ट प्रॉन्ग्स भी होते हैं। एंड वी एज्यूम कि जितना भी फ्लो रेट हम बढ़ा रहे हैं उससे 4% FiO2 बढ़ रहा है। सपोज वी स्टार्टेड विद 21%, अगर हम 1 लीटर देंगे तो इट विल बिकम 25%। अगर हम इसको 2 लीटर पे कर देंगे तो वी एज्यूम दैट इट इज बिकमिंग 29। दैट इज व्हाट वी आर अज्यूमिंग। वी डू, इट मे नॉट बी द सेम डिपेंडिंग ऑन द पेशेंट्स एफर्ट्स, प्रॉन्ग का साइज क्या है, so all those things. So that's why we call them a variable performance system, because it's very helpful for long term oxygen delivery, क्योंकि पेशेंट खाना पीना खा सकता है, कंफर्टेबल है। Then there comes a simple face mask. सिंपल फेस मास्क का अगर 5 से 10 लीटर पर मिनट की हमें ऑक्सीजन देनी है तो एक सिंपल फेस मास्क यूज करते हैं। इधर से ऑक्सीजन आता है, ये जो दोनों है इसके एक्सहेलेशन पोर्ट्स हैं। एक्सहेलेशन पोर्ट्स खुले हुए होते हैं, तो जब पेशेंट इंस्पायर करता है तो जो उसकी एक्सपायर्ड एयर भी होती है वो भी अंदर जाती है। दैट्स व्हाई दीज आर कॉल्ड एज रीब्रीदिंग। इसमें रीब्रीदिंग हो रही है, इसमें जो आप बाहर निकाल रहे हो वो अंदर जाता है, बिकॉज ये दोनों आप अगर देखें ये जो दो पोर्ट्स हैं खुले हुए होते हैं। दैट्स व्हाई whenever if you give low flow with these अगर आप ऑक्सीजन कम दे रहे हैं, रीब्रीदिंग ज्यादा हो रही है, तो हाइपरकार्बिया इन मास्क में हो सकता है। Quickly talking about non-rebreathing mask, क्योंकि ये वाले मास्क जो है they have been become a savior in COVID times, जहां भी low resource setting थी वहां पर NRBMs have worked beautifully. So NRBM को हम non-rebreathing mask क्यों कहते हैं? It gives you 90 to one good advantage is you can give up to 90 to 95% of FiO2. इससे हम 90 से 95% तक का FiO2 दे सकते हैं। Again, depending on the patient's condition. Why we call it non-rebreathing is that here we saw that these exhalation ports are open. यहाँ पर जो exhalation ports होते हैं, these are valve. तो जब भी पेशेंट एक बार एक्सपायर कर लेता है एयर को, तो ये वेल्व इनहेल करते वक्त इसी तरह से ये जो रिजर्वॉयर है इसमें हमेशा ऑक्सीजन आकर जमा रहती है, और इधर भी एक वेल्व होता है। तो जब हम एक्सपायर कर रहे होते हैं या एक्सेल कर रहे होते हैं तो ये वाले वेल्व्स खुल जाते हैं और ये वेल्व बंद हो जाता है। सो द पर्पस इज आपको ये समझना चाहिए कि जो भी ऑक्सीजन आ रही है यहाँ से आ रही है, जब पेशेंट यहाँ से ऑक्सीजन ले रहा है ये वेल्व्स बंद हो जा रहे हैं। सो देयर इज नो एक्सटर्नल एक्सेल्ड एयर कमिंग इन। So we assume कि जितना हम ऑक्सीजन यहाँ से रिजर्वॉयर से वो हमारे पेशेंट को मिल रहा है। That's why we call it a non-rebreathing, and it gives you about 90 to 95% oxygen. Only thing is you have to be very careful कि आपका ये जो रिजर्वॉयर है वो आराम से वो लीक ना हो। These valves should be working properly. All these things have to be seen. So this is a non-rebreathing mask. इसमें सब कुछ दिखाया गया, which I have already shown you कि these are the valve mask. एक mask यहाँ एक valve यहाँ पर भी होता है। Okay. Now case continued. We have to remember that this child actually Ram, he came to us in impending respiratory failure. हमने देखा था respiratory rate 46 था, तो उस वक्त obviously we started him with non-rebreathing mask. But after an hour when we And I always told you that you have to remember, evaluate, identify, intervene. तो अगर आपका पेशेंट का उस वक्त सैचुरेशन अच्छा भी है तो आपको इवैल्यूएशन, इंटरवेंशन जारी रखना है। तो अगेन now we saw that this Ram's conditions was deteriorating. His SpO2 was 88% on non-rebreathing mask. The child was lethargic, and we saw that his ABG values, pH is 7.34 actually. pH was 3.74. So there was some 7.3. PO2 was 70, which is acceptable. PaCO2 जिसका कि वैल्यू 35 से 45 होता है वो 55 हो गया है। तो we know कि बच्चे को रेस्पिरेटरी एसिडोसिस भी हो रही है, because you see pH, when pH goes down and PCO2 goes up, we know that this is respiratory acidosis. सिवियरिटी हमने देखा PaO2, ये आपको बताया था कि रेशियो ABG में PaO2 और FiO2 हम ऑलरेडी 90% दे रहे थे। We calculated PaO2 and FiO2 was 87. SpO2 by FiO2 was 110, which is again showing severe respiratory distress. So What next? We have to move to a higher modality. We know that our NRBM is not working. Here is the role of HHHFNC, जिसको हम कहते हैं heated, humidified and हाई फ्लो डेजल कैन्यूला. जैसे इसमें हमने बताया था कि आपको 15 लीटर पर मिनट से ज्यादा नहीं दे सकते हैं. HFNC is a device which may give up to 60 liter per minute of oxygen. So let's see a video and know more about HFNC. Dr. Singh, could you please play the video? Hello. Hello.
Dr. Rajesh Kumar Meena, Associate Professor in the Department of Anesthesiology. Today we'll discuss about the high flow nasal oxygenation therapy. It is a high flow nasal oxygenation therapy, and we'll discuss about the also known as HFNC or HFNO. HFNO is high flow nasal oxygenation, HFNC is high flow nasal cannula. Okay. In this video, first we'll discuss what are the parts of this machine. Okay. So first part is, this is a water bottle, distilled water, and this is a tubing line attached to the humidifier. This is an active humidifier plate. And another part is this is your breathing circuit. This is humidified, heated breathing circuit. See, this is the machine hand. You can see it. You have to just press it there. Like this. Now, and this is your patient hand. Okay. Now coming to the another part. This is the nasal cannula. This is the nasal cannula. This is a separate part. You have to attach it with this. Now it is assembled. This is patient hand. And another part is the flow meter. You can see this. This is a specifically designed flow meter to give up to a 6 liter of flow. You can see this start with a 5 liter and end up to the 15 liter of flow. You can see it. Now how will you put to your patient? See, like if this is your patient, just you have to attach it like this, and this should be snugly fitted in this, and by behind you can strap it. Just make sure that this should be snugly fitted. Okay. Now coming to the settings. What settings you need to in HFNC before starting? You have to set 3 parameters. First is the flow. Start with 20 liter per minute and goes up to the 6 liter per minute in Fisher Paykel, and in some machines 80 liter per minute. Second is your temperature. You have to set at 37 degree of temperature inside the machine, and ultimately last one is a FiO2. You start with the 80% of FiO2 and go up to the 100% of FiO2. Now I will show you, will demonstrate you that how this machine works. This is on and off button. You can see this is on and off button. These are buttons for up and down, and this is for select. Now you can see in the screen, first is the 35 degrees Celsius. This is your temperature. By pushing both the buttons simultaneously, see it is 37. Now you can select it 37. Okay. Now again press it. This is your flow. You have to set 60 liter, or you can go down. Okay. Now by this you can decrease your flow like this: 50, 40 and 25, 20, like this. Okay. And another is your FiO2. You can increase your FiO2 by increasing your flow rate. You can see that it is a 20 liter of flow, and here you can see what is FiO2. It is a 95% of FiO2. Okay. And then I will increasing it. This you can see this 30 liter and my FiO2 is 100%. So by increasing just oxygen flow, your FiO2 is set. And the most important thing is, just you can set it, your FiO2, you can decrease it, and you can increase your flow also. Basic settings of high flow nasal oxygenation therapy.
Okay. So we briefly discussed about HFNC, जिसको कि कहते हैं high heated, humidified, high flow nasal cannula. Advantages, we have to know that this has come to the rescue of many patients in during COVID. It is heated, humidified, high flow, high FiO2 device. This is more comfortable. Children better tolerated. Adults में बहुत बार BiPAP वगैरह use हुआ है, but children have nicely tolerated HFNC. The major advantage is that because you are giving oxygen in such high flow, it flushes whole nasopharynx with oxygen. जो nasopharynx and upper airway, which is usually becomes a dead space, it becomes as a reservoir. यहाँ पर हमेशा oxygen will be there. And because you are giving high flow oxygen, it also gives you some PEEP. PEEP is positive end expiratory pressure. ये एक ऐसा pressure होता है which will help your alveoli not to collapse at the end of expiration. This is the pressure. So even with this high flow, some PEEP is also exerted. And apart from that, because you are giving heated and humidified air, so it will ensure a good mucociliary clearance. So it usually gives a So what are the indications? We should know that whenever a patient fails to maintain the target SpO2, if you are using face mask of more than 5 liter per minute, oxygen hood से आप use कर रहे हैं, या non rebreathing mask जो हमने सबसे पहले RAM पे use किया था, अगर if that is not working, then we use HFNC. But if there are pneumothorax, pneumomediastinum, then we should not give such a high flow. And if a patient has multi-organ compromise, if a patient has severe respiratory acidosis, we should refrain from using HFNC. So HFNC कैसे start करना है? The video already showed you. You have to use nasal prongs, which should be around 50 to 75% of the nares of the patient. Usually, आपका जो maximum flow होता है premature patients के लिए 8 liter per minute, but you should remember about pediatric and infant में 20 liter per minute तक का flow हम दे सकते हैं, और pediatric age group में 25 liter per minute तक का flow हम दे सकते हैं. तो usually हम start करते हैं 0.5 to 1 liter per kg per minute. तो suppose अगर 10 kg का बच्चा है तो 10 into so you can start up from 10 liter per kg per minute तक आप यूज कर सकते हैं, and if required 10 into 2 is 20 liter per kg per minute तक आप increase कर सकते हैं. So depending on the weight also you can fix, but you have to remember that in pediatric usually use 25 liter per minute तक का flow. And what should be our target? Our target should be to maintain a respiratory saturation of 90 to 94%. Because you are using it with the nasal cavity, तो आप, because this is COVID era, आप face mask 3-ply mask से face cover कर सकते हैं. Again, हमेशा evaluate करते रहिए. Every 1 to 2 hours, you have to monitor heart rate, respiratory rate, SpO2. अगर कहीं पर भी we feel that this is not working well, we have to escalate the therapy. There's one index called ROX index, which will help you to know about the failure or success of HFNC. बहुत simple है. SpO2 आपको दिखता है monitor में. FiO2 आपको पता है कि आप कैसे set कर रहे हैं. You can easily set in a HFNC device. So SpO2 divided by FiO2 divided by the respiratory rate of the patient, you calculate. So if ROX index is less than 2.85 in 2 hours, less than 3.47 in 6 hours, or 3.85 in 12 hours, then this is a sign of HFNC failure. Halaki, if it is more than 4.8, it shows that mostly the patient will be well weaned from the HFNC device. Again, if this HFNC is not working, what do? We move one step up, that is non-invasive ventilation, where you do not intubate or put an endotracheal tube to the patient. इसकी modalities है CPAP or BiPAP, जिसका की detail next session में होगा. I'll be briefly touching these topics. So what are the advantages? No sedation or paralysis is needed. Intact natural airway clearance mechanism, because we are not putting an ET tube. No mechanical trauma related to ET replacement. So if there is no response to HFNC device in 1 to 2 hours, please move upon these therapies and we can try non-invasive ventilations. What are the contraindications? They are same as HFNC, like pneumomediastinum, bleeds, facial injury, upper GI bleeding. Quickly talking about bubble CPAP therapy. Bubble CPAP is a device जिसमें कि we give CPAP is continuous positive airway pressure. So एक continuous pressure हम बाहर से देते हैं so that there's this airways do not collapse and you give a certain pressure. So this is known as continuous positive airway pressure. This is a simple machine जिसमें कि आपका एक bubble CPAP generator होता है. Bubble CPAP generator is where आपका जो when you put a CPAP assembly, तो उसमें I'll just show you. So this expiratory end जो आता है bubbles यहाँ पे CPAP पे आता है. There is a blender जहाँ पर कि आप FiO2 fix कर सकते हैं. This is a humidifier which gives again heated humidified air. So it delivers one constant pressure. Inspiratory और expiratory same pressure ये deliver हमेशा करता रहता है. Patient should breathe spontaneously. We should remember that जब भी हम HFNC, CPAP, BiPAPs use कर रहे हैं, you don't have to sedate the patient because these devices are supporting. ये क्या कर रहे हैं? Patient को support कर रहे हैं. Patient को artificially breaths नहीं दे रहे हैं. तो never sedate. अगर आपको लगता है बच्चा struggle कर रहा है, तो हम CPAP काम नहीं कर रहा कि हम sedate कर दें. No, that is an indication that there is a CPAP failure. Don't sedate. The patient will further deteriorate. So in this, the patient controls both the rate and depth of the breathing. So bubble CPAP type जो हम use करते हैं usually in ICUs में, but infants में use कर सकते हैं. Basically इसमें भी बहुत simple है. जैसे उसमें आप लोग इसमें आप flow set करते थे, तो अपने आप ही FiO2 set हो रहा था. Similarly यहाँ पर FiO2 we can set between 21 to 100. प्रेशर जो कंटिन्यूस पॉजिटिव एयरवे प्रेशर है वो हम 4 से 7 सेंटीमीटर तक सेट कर सकते हैं. दैट इज सेट व्हेन वी जो एक्सप्रेटरी लिम्ब है उसको हम बबल के अंदर डालते हैं. देयर आर मेनी यूट्यूब वीडियोस वी हैव गिवन यू अ लिंक ऑफ इट. आप उससे भी देख सकते हैं. उसके बाद वी कैन सेट अप ऑक्सीजन फ्लो ऑफ 2 to 7 लीटर पर मिनट. दो हियर इट इज रिटन FiO2 of 100%, but one important tip I want to give you कि जब भी पेशेंट को 60% से ज्यादा CPAP में a good way of starting is a rule of 5. जब आप स्टार्ट करते हैं तो 50% FiO2 सेट करिए, 5 का प्रेशर सेट करिए और 5 का ही फ्लो. सो 5, 5, 5 तीनों को 5 में सेट करके हम स्टार्ट कर सकते हैं. डिपेंडिंग ऑन सिचुएशन बढ़ा सकते हैं, पर कभी भी किसी पेशेंट को अगर प्रेशर 7 से ज्यादा की आवश्यकता हो रही है, फ्लो 7 से ज्यादा और FiO2 60% से ज्यादा है, तो दिस इज अ साइन ऑफ CPAP फेलियर. वी शुड नॉट वेट फॉर द पेशेंट टू डिटरेट कि हम 100% FiO2 बढ़ा दें. If it's 60% we are done. अगर यहाँ पर पेशेंट मेंटेन कर रहा है तो बहुत अच्छा है, नहीं मेंटेन कर रहा है तो this is an indication we may have to intubate and ventilate the patient. So this is a device. ये आपका expiratory limb है, ये यहाँ पर डिप हो जाता है, यहाँ पर प्रेशर सेट किया जाता है, यहाँ से आपका ऑक्सीजन आ रही है, एक कंटिन्यूस प्रेशर पेशेंट को मिलता है इसमें. Again, quickly touching the BiPAP. BiPAP का नाम हमने खूब सुना है, adults में बहुत यूज हुआ है. This is known as bi-level CPAP. जैसे CPAP में we were fixing केवल एक प्रेशर, अगर मैंने 7 का फिक्स किया तो आपका इंस्पिरेटरी और एक्सपिरेटरी दोनों में 7 का ही प्रेशर जाएगा. BiPAP gives you 2 kind of pressure. It gives you EPAP and IPAP. IPAP is inspiratory peak airway pressure. EPAP is expiratory positive airway pressure. क्योंकि we always know कि हमें जो expiratory pressures होते हैं वो कम रखने होते हैं. So here you can fix both IPAP and EPAP. And also there are इसमें काफी modes भी होते हैं. Sometimes timed mode. You can if a patient's respiratory efforts are not very good, you can set some respiratory rate also. So these are the assemblies. BiPAP would be discussed in the next session again. Now again, coming to the same case, we have used HFNC in this patient. We saw that for some time this patient was responding well, but suddenly we saw this patient started deteriorating and this child's pulses were fast. He was cold to touch, BP had dropped down, SpO2 was 80%, ABG again showed 7-point pH has further dropped, PaCO2 from 50 has increased to 60. The severity is now severe respiratory failure, and we all know that this patient requires invasive ventilation. So the patient should be immediately intubated and shifted to the invasive mode of ventilation, which will be discussed in great detail tomorrow. So so in this lecture, we have learned about all these devices. I think few things are clear to you. If then things are not clear, we are again there to help you out. And again, a lot of thanks to the contributors, Professor Lalit Meena, Professor Sunil Kumar Rao, Associate Professor Dr. Rajesh Meena, who are taking the next lecture for preparing this video. Thanks to the organizers for giving me this opportunity. I think the next session, which you all are waiting, is how to use non-invasive ventilation in children. We'll be discussing in great detail in BiPAP and CPAP. And for this, I welcome Dr. Rajesh Kumar Meena. He's Associate Professor in Anesthesia in IMS BHU. So welcome, sir, and you can start your lecture.
Thank you, ma'am, for your wonderful lucid presentation on oxygen therapy. Actually, you did my job very easy, as you already described about the oxygen therapy, HFNC, CPAP, and BiPAP. Now, I think I have to just summarize all the things in a lucid way. So, my slides are visible?
Yeah, your screen is visible. I think you have to open the slides. Yeah, see.
Okay, fine.
Yeah, see.
So first, I just would like to say one thing, that if you have any queries regarding this lecture, you just type your questions in the chat box. We'll take all the questions at the end of the session. Okay, so we'll go with the non-invasive ventilation. Basically, non-invasive ventilation, see, there is two types of ventilations. One is non-invasive and another is invasive. Okay, so non-invasive means you are not doing any invasive procedure to the patients. Okay, in invasive ventilation, you are using an endotracheal tube as an assisted device to provide a ventilation. But in a non-invasive ventilation, you are just giving ventilation by the simple face mask, oronasal mask, nasal mask, or a helmet. These all are the interfaces that you are using to give ventilation to your patient. Okay. So the basic difference between non-invasive and invasive is only the use of endotracheal tube, or in non-invasive, we are using a basic interfaces. Okay. So when you want to use non-invasive ventilation and when you want to use invasive ventilation, so it is we'll discuss what are the indication of NIV, what are the contraindications of NIV, how will start NIV, means what are the steps to put a patient on NIV, and lastly, what are the complications of NIV. So basically, NIV is started because the invasive ventilation have a few complications or harms to the patients. So by avoiding these procedures, these invasive procedures, and just providing a ventilation for a shorter period of time, we can go with the non-invasive ventilation. So NIV having a strong indications, like in adult patients per se, like acute exacerbation of COPD or type 2 respiratory failures. But as we are discussing only regarding the COVID, so in which patients you will use non-invasive ventilation and in which patients you have to use oxygen therapy. See, as in previous lecture, the ma'am told you that the oxygen devices, that their fixed performances and high flow devices. These all oxygen devices are used in the initial stage when your patient is in type 1 respiratory failure. Okay, means the patient's saturation is on the lower side, but his or her ventilation part is okay. So in that case, you have to use all the oxygenation support. But when your patient is having respiratory distress, increased work of breathing, and having fatigue, and it is apart from these all findings, your patient is hemodynamically unstable, then you go with the non-invasive ventilation. Okay. So with these all lines, we'll start that endotracheal intubation carries potential risk, including VAP and laryngotracheal damage. Okay, these are the side effects of your intubation. So how NIV works? NIV assist. Okay, see, NIV is all a spontaneous mode. It is not a control mode. So you are assisting your patients. Assisting in what terms? You are giving a pressure support or a PEEP to the patient that it will unload the increased work of breathing. So it is a spontaneous mode, not a control mode. Okay, and you are just assisting your patients, not controlling the ventilation. Okay, so if your patients are getting fatigued on NIV, you have to certainly switch the non-invasive to invasive ventilation. Don't waste much time by increasing your supports of more than 20 centimeter water. So maximum limit of your IPAP should be 20 centimeter water. If your patient is requiring more than 20 centimeter water, then your patient is a potential candidate for the invasive ventilation. Okay, so an IV assist in distending the airways, improve oxygenation at the alveolar level by giving a PEEP. Okay, PEEP is a positive and expiratory pressure. It unload of respiratory muscles, decreasing breathing efforts without the need of an invasive tracheal device. So an IV in acute setting has been found to improve outcome and reduce the need of intubation. Okay, so see, if you are giving non-invasive ventilation at the earlier stage, means your patient is starting or dipping from type 1 to type 2. In that transition phase, if you are used early non-invasive, you can stop the disease process or your respiratory failure patient at that time, and your patients might improve. Otherwise, the patients will need intubation, and here a vicious cycle will start, and there will be so many complications will happen. Now, coming to the non-invasive ventilation definition, as such, there is no standard definition of NIV, but just to enlighten you, that use of positive pressure without a endotracheal tube that I already told you, and using an interface. So the complete definition will be use of positive pressure with an interface and without a invasive airway device. So respiratory assistance is provided by using pressure greater than atmospheric pressure to drive the air into the lungs. So basically we are pushing the air into the lungs by giving extra pressure, or you are assisting the patient's inspiration. Okay. So avoid risk and complication associated with endotracheal intubation and mechanical ventilation that we already discussed. So patient selection and proper mask interface is crucial. So this is the most important thing you have to be keep in mind while you are giving non-invasive ventilation to your patient. Okay. So what about patient selection? Okay. See, your patient should be fully conscious. His GCS should be more than 13. He is able to follow your commands and able to secrete out his own secretions. He should be hemodynamically stable, and that disease progress should not be worsened. So these are all the indications, or we can say these are the factors. By seeing these, you can select if your patients come under this category, you can go with the non-invasive ventilation. If your patient does not fit into these all criteria, you will have to go to the invasive ventilation. Another thing is a proper mask interface is proper mask means we have different type of interfaces, like we'll show you in later slides, like oronasal, nasal, complete face mask, just a nasal prong, a nasal CPAP, or a complete hood, or we can call it as a helmet mask. So commonly we use is a oronasal face mask. And after the selection of a proper interface, you have to see a proper size of the interface, because if your size will not proper, there will be a air leak around it, and it will cause a trauma to the nasal bridges or and all. So you have to keep these 2 points when starting an NIV. So types of non-invasive ventilation, there is a 2 types. One is BiPAP. Basically, in modern ventilators, you can give NIV by all modes like SIV, volume control, pressure control. But the basic modes of non-invasive ventilation are the BiPAP or CPAP, or one is a PAV, that is a proportional assist ventilation. So what are the learning goals? Identify the respiratory failure, means what are the type 1 or type 2 respiratory failure. As I think in previous class, you already pre-conditioned about these type 1 and type 2 respiratory failure, and how to recognize it by seeing your symptoms, doing an ABG. Strategy to treat NIV means what will be the NIV settings. You have to give CPAP, where you have to give CPAP, where you have to BiPAP, what interface you will have to select, what will be the initial settings, what monitoring required during the non-invasive ventilations, and what are the predictors of failure or success of non-invasive ventilations, and lastly the complications. So what are the NIV benefits? As we already discussed, it assists in workup breathing and allows respiratory muscles to rest. It will decrease your workup breathing and decrease total oxygen consumption. It decreases hypercapnia by assisting the ventilations and wash out the CO2. The patient can stay awake and sedation is not necessary. See, it is not necessary. As even in the previous class, ma'am also told you, you have to keep awake your patients during non-invasive ventilation, and your patient should not be restless, should not be anxious. But see, if your patient is anxious because of his any psychotic or because of this flow, you can give a conscious sedation to that patients, like you can use dexmedetomidine in that patients. But in pediatric patients, you have to avoid it. In adults, you can go with the low dose of sedations. So your patients the tolerance would be better in that cases. So it avoids complications of all endotracheal tubes. It increases your functional residual capacity through your EPAP. It will intact your natural airway clearance, as already discussed. No mechanical trauma, no tissue trauma, no airway trauma, no VAB, no sedation, no paralysis, and no CIPM, And if you are giving sedation, paralysis, your ventilation time will increase, your ventilator dependency will increase, and ultimately this will lead to the difficult weaning. So by giving non-invasive ventilation to as earliest point, you can save your patients with these all complications. So now, when not to use, see, in every situation, it's better to see the scenarios where you should not use, or I can say you must not use non-invasive ventilation. Like if your patient develops cardiorespiratory arrest, in that case, you have to secure a definitive airway by giving LMA. If you are not confident on endotracheal intubation, but don't use non-invasive ventilation in case of cardiorespiratory arrest. And if patient is having a GCS less than 8, you should not use. It is a first and foremost requirement to start with the non-invasive ventilation, that your patient must be following your all commands, and GCS should be more than 30. Your patient should be hemodynamically stable, means there should no vasopressor requirement, and mean arterial pressure should be more than 65. There should be no MODS. There should be no upper GI bleed. Otherwise, if you are giving non-invasive ventilation, the sum of air will goes into the stomach, and it will increase your intra-abdominal pressure, and your patient might got aspirated because your airway is not secure. So if he is having a not having a protective reflexes, in that case you should not use. Having a facial injuries or craniofacial deformities, in that case your interface will not be fitted well. The patient will complain pain, and he will not tolerate the interface. And another will be the uncooperative patients. In that patients, you cannot use non-invasive ventilation because he will always complain, "Doctor, isko hata lo, problem ho rahi hai," and all that. And pneumothorax without a chest tube in place is, in that case, you have not to use non-invasive ventilation. Now, a little bit about the respiratory failures, like when you will call type 1 and when you will call type 2. बाद में हाँ शाम को see, if you are having an increased respiratory rate and having all the signs, you will call it a distress. And when it became your decreasing in PO2 levels, it became a failure. And when it will increase your PCO2, means hypercapnia, it will cause ventilatory failure. So oxygenation failure or ventilatory failure. So if patient is just simply hypoxic, just dropping his PO2 levels or SpO2 levels without rising the PCO2, means it is a type 1 respiratory failure. And it is having a ventilatory failure, means it is a type 2 respiratory failure. So it is a vice versa, that your patients came with a type 1 respiratory failure, but because of increasing the progression of disease, the patient might land up into the type 2 respiratory failure. So how will you recognize that the patient is having a distress or failure? So if your patient is having distress, these are the signs like tachypnea, chest retraction, grunting, stridor, nasal flaring, and use of accessory muscles. So if your patient is having all these signs, means your patient is in respiratory distress. And all these findings lead to the increased work of breathing. And in case of respiratory failure, your patient will showing the hypoxia, the saturation will be less than 92%, hypercarbia, PCO2 level should be more than 50, and the patients might show the respiratory acidosis with the pH of less than 7.35, and showing the signs of fatigueness. And ultimately, because of raised CO2 levels, your patients might decrease the consciousness, and it will goes into the coma and ultimately into the respiratory arrest. So distress, failure, and arrest. So what would be your strategy? So non-invasive ventilation delivers ventilative support without use, and as we already discussed, do not require endotracheal intubations. You can use it at home with the proper guidance of any physician or in hospital. Basically, if you are requiring non-invasive ventilation, you must be shifted to a hospital where where a different monitoring will be functioned. So what are the roles of non-invasive ventilations in case of OSA, in type 1 and in type 2 respiratory failure? Basically, non-invasive ventilation roles start only in type 2 respiratory failure. If patient is having type 1 respiratory failure, you go with the high flow nasal oxygenation therapy. Your patients will get improved, but the situation is worsening and you are thinking that his ROX index is less than 3.85 and it is showing that patient is going into the HFNC failure, you can switch from HFNC to NIV, but don't use initially non-invasive ventilation in type 1 hypoxemic respiratory failure. So the mechanism we already discussed. Now coming to, these are all two types we already discussed. A little bit that basically CPAP is just a EPAP. It is an expiratory positive airway pressures. So it is just to keep your alveoli open at the end expiration and improve the ventilation perfusion. Okay. So it will improve your oxygenation and will decrease your work of breathing. And BiPAP, in BiPAP, you will give both IPAP and EPAP. IPAP is an inspiratory positive airway pressure to assist, and EPAP is just a P to improve the oxygenation. So when you are having type 2 respiratory failure, use BiPAP. So CPAP and BiPAP both delivers positive pressure throughout a non-invasive interface. It delivers a constant descending airway pressure throughout the entire respiratory cycle. Basically, CPAP is a throughout, means in inspiration as well as expiration. So increase oxygenation and CO2 washout by expanding, collapsing, and recruiting the lung volumes. It reduces the work of breathing, preventing apnea by stunting the upper airways. BiPAP uses two pressures, IPAP and EPAP. IPAP is delivered to the patients when the device senses the patient is initiating a breath. Means it is a flow trigger. Okay, it is a flow triggering. Means a patient will initiate a breath, the machine will sense, and it will give a positive pressure, and the cycle will terminate. Okay. So you have to use a double circuit for using non-invasive ventilation. These are all the interfaces as I already discussed. Use of HME filters, because when you are using a flow of more than 30 liters per minute, a dry oxygen without humidifier, your patient will suffocate and it will decrease. Basically, it will increase the vasoconstriction and decrease your ventilation perfusion. So always use humidified gases by an active humidifier or passive humidifier. Active humidifier is the humidifier which is inbuilt in the ventilators. There is a plate that will heat and it will transmit to your oxygen. And the passive humidifier, these are HME filters that will humidify the expired humidified exchange with the expired humidified. So active and passive humidification. So always active humidification is better than passive humidification. Okay, but if you don't have the facility of humidifier, you can use HME filters. The patient is in isolation room with negative pressure ventilated rooms. So these are the photos of bubble CPAP and CPAP circuits as this is a photo of humidifier. Here, this is a bottle, and these are the settings. You have to set the temperature at 37 degrees Celsius. Okay, and you can see here the temperature is showing 36.8. This is a photo of Hudson prong interface. This is also type of interface. This is you called is a standalone BiPAP. The machine is called standalone BiPAP. Nowadays we are using mostly the BiPAP with our integrated ventilators that having the option of non-invasive and invasive both. So, but if you don't have that kind of facility, you can go with the standalone BiPAP that we are commonly using in your wards. So the important thing is get used to your BiPAP machine, because the on and off buttons, the up and right buttons and settings are different in different BiPAPs provided by the different companies. So you have to be familiar with your BiPAP. So what are the common initial settings? You have to set an inspiratory pressure, means IPAP. You have to start with the low pressures like 8 centimeter of water, and you can increase 2 centimeter of water in further readings. Okay, you have to set a EPAP. Initially you have to set around 5 centimeter of water, or actually if you have a modern ventilator facilities, you can check the auto PEEP and you can set your EPAP according to their auto PEEP. Set the FiO2 to 100% and titrate according to the requirement of the patients, and your target FiO2 should your target SpO2 should be between 92 to 94. Okay, initially you have to keep IE ratio as 1:2, and you have to set a backup rate as per required. So it is all about BiPAP. As I already told you, you have to start with this, EPAP this, and gradually increase by 2 centimeters and maintain this. Okay, this is a picture showing a nasal CPAP to the patient. You can see it is a single limb. HFNC, as ma'am already discussed in previous lecture. Well, so basically HFNC is a high flow nasal oxygen therapy. You can set a flow of 60 liters per minute, FiO2 between 100, and it is all heated and humidified gases. You have to set a temperature around 36 degrees centigrade. How HFNC work? Basically, it is having a PEEP effect. When your mouth is closed, around 5 centimeter of water PEEP generated, and if your mouth is open, around 3 centimeter of water PEEP generated during HFNC. So it is a picture showing, this is as we already showed in the videos. Basically, the advantage of HFNC over NIV or CPAP is that the tolerance of HFNC is far, far better than a CPAP because of its interface. Because in CPAP, you have to seal all oronasal mask, and HFNC just a simple cannula. Your patient can feed, your patient can talk, your patient can cough out without removing the interface. Okay, so these are the all advantages of HFNO over a CPAP with the ventilator. Okay, so if your patient is just requiring a CPAP, means only PEEP of around 5 centimeter water, means your patient is in type 1 respiratory failure, I think you go with the HFNO. Now, how will you start your CPAP? Connect the oxygen outlet with the tubes, set FiO2 initially at the 30% and increase according to the requirement. You have to set the humidifier temperature between around the 37 degrees Celsius. And in pediatric patients or infants, you have to lower down this temperature around 36. Basically, in HFNC, there is a mode. When you will switch the mode to adult to pediatric, it will automatically set the temperature around 36 degrees centigrade and flow limitations. This is all the safety features of HFNC. Set a PEEP of around 5 centimeter water and titrate as needed. Connect circuit interface to the patients and monitor the heart rate, respiratory rate, and saturation. So, what are the pitfalls in NIV? As already discussed, because pediatric interface, the dead space in adult interface is too big for children. So, use of pediatric interface. As I already told you, the interface selection is most crucial while initiating an NIV. Patient cooperation level of consciousness is very much required. Okay. If the patient is agitated and still does not tolerate after 1 hour, NIV is probably failing and sedation will not resolve the situation, as I already told you. Choosing the right time to introduce non-invasive ventilation earliest. Okay. As I told you, the sooner is the better. And the interface should be adequate. There should be no air leak. There's some videos on the YouTube you can watch over there. So now coming to all the interfaces we have, like we have all the interfaces: nasal prongs, nasal mask, oronasal, total face mask, and helmet mask. Helmet mask are only available for the adult patients. Okay. So these are the cannulas, these are the nasal mask. By giving this, you can give a nasal CPAP. And these are interfaces. This is nasal CPAP. You can see here nasal mask, oronasal, full face mask. And this is the helmet mask, most advanced one that we have, but not for pediatric patients. Okay. Now coming to the some case scenarios, what initial settings you have to set when your patient is in type 1 or type 2 respiratory failure. You can see in type 1 respiratory failure, there should be a mild hypoxemia, increased work of breathing, and there is no hypercapnia, means your patient is in type 1 respiratory failure. In patients type 1 respiratory failure, you can go with the HFNO and CPAP. And in type 2 respiratory failure, when their work of breathing is much more and having a severe hypoxemia as well as hypercapnia. So in case you have to go with the BiPAP. So in HFNO, what settings? HFNO, you have to set a flow. In pediatric patients, you have to set a 2 liter per kg per minute for first 10 kgs and 0.5 liter per kg per minute for the rest of 10 kgs. Don't go beyond 20 liter per minute in pediatric patients. Okay. And in CPAP, initially you start with the 3 to 5 centimeter water and go up to the 8 to 10 centimeter water. And in BiPAP, you have to set IPAP at 8 centimeter water and EPAP around 5 centimeter water, and gradually increase by 2 centimeter water, and maximum you can go IPAP up to 20 centimeter water. And your target should be 92 to 94 of SpO2. Okay. So what monitorings you require? You require more careful observation initial 2 hours, because in these time, your patient might get deteriorate and you have to switch to the non-invasive to invasive ventilation. So initial 2 hours are more crucial and you have to be more vigilant. Even I can say, by putting your patients on non-invasive ventilation, you have to be on your toes. Okay. One of the resident or staff should be stand along the bedside during the initial hours, because in that case your patients will having all the problems, like because of interface problems, because of flow, and because of agitations. After that, as your patients become familiar or accustomed to these all flows, then it will slowly improve. Child should be nil orally and IV fluids. Nowadays, some of trials studies showing that you can start enteral feedings even on non-invasive ventilations. Okay, and the monitorings required are heart rate, respiratory rate, pulse, saturations, chest, work of breathing by seeing all the respiratory signs, patient tolerance or synchrony, interface leak, and periodic ABG. Okay, these are all the monitorings you have to see, or you have to be vigilant during the initial time. This helps in picking early, so your patients might need invasive ventilation. A good response to non-invasive ventilation typically manifests in 2 hours. So what are the criteria of NIV failures? Means when you will have to decide that now it's time to go for the intubations. First is a clinical worsening, means your symptoms are worsening, your fatigue is worsening, your respiratory rate is more than 40, your hypoxia is worsening, and there is no improvement of dyspnea. Respiratory rate is increasing work of breathing. FiO2 requirement is more than 60%. There is asynchrony between the ventilator and patients. Need of high positive inspiratory pressures like more than 20 centimeter, PEEP more than 12. See, you can see these values. If your patient is requiring more than these settings, that means you have to intubate your patients, and don't waste time by putting your patients on IV and extending the non-invasive ventilation. Okay, so the sooner is better in both the conditions, to start NIV and to terminate the NIV. Okay, so worsening of blood gases means your pH is deteriorating, as in 7.2, PCO2 is increasing, and lastly the refusal of patients or relatives. As I already told you, the patient cooperation is the foremost thing for a success of non-invasive ventilation. But in case of pediatric patients, this is not work. And lastly, the GCS of less than 8. So do not delay endotracheal intubation if patient is not improving quickly on an IV, as this can lead to the worsening the condition and unfavorable condition for intubation. Means you are in a situation of elective intubation, and by delaying your intubation and by extending non-invasive ventilation, you are creating a crisis situation, and an emergency intubation you have to be done. Okay, so you have to manage accordingly. Frequent assessment of whether the patient is improving or critical. So NIV is basically, you have to be very vigilant. You have to stand side by the patient. In invasive ventilation, you can go and sit, but if you are putting a non-invasive patient on NIV, you have to be very vigilant. Now coming to the complications. See, these are all the predictors of failure, as we already discussed. Now coming to the complications. Complications are not improving oxygenation or ventilation, pressure damage of the skin of the nasal breezes, nasal cannular prong obstruction because of secretions, nasal dryness because of your humidifier is not working, gastric distension because you are giving up high inspiratory positive and pressures, so it will increase your gastric distension and ultimately lead to the intra-abdominal pressures. So you can put a rice tube in that type of patients. Non-invasive ventilation can cause barotrauma as well as volutrauma also, and air leaks are the most problematic condition in non-invasive ventilation. So you have to choose a good interface to avoid all air leaks. So these are all the references of this slides. So what skills you have to be enhanced? You are able to recognize distress versus failure. Means what? When you will say that your patient is in respiratory distress, when you will say your patient is in respiratory failure, and lastly, when you will say what is the respiratory arrest situations. Familiarize with the basic terms of ventilation like peak inspiratory pressure, positive and expiratory pressures, BiPAP, CPAP, FiO2, tidal volume, flow triggering, cycling, pressure cycling or time cycled, what is minute ventilation, what is the respiratory rate, devices, familiar with devices, CPAP devices, BiPAP devices, standalone BiPAP, standalone CPAP, what is HFNC, and what are the interfaces, what are advantage and what are the disadvantage, how to initiate, how to detect the failure and complications. Now, I think this is all done. So,
yeah, please
if
continue.
we have the queries of all attendees, we can take one by one.
As of now, I don't see any questions, and thank you, Dr. Rajesh, for such a lucid presentation and making the concepts clear about these devices, which usually give us a jitter before we use them. And so thanks a lot for this presentation. And before we move to a very important, okay, now there's one question, Dr. Rajesh. Sir, what about ECMO technique?
Question about what?
It's about ECMO, ECMO, extracorporeal membrane oxygenation.
Okay. Actually, basically, ECMO is beyond the discussion of this topic. But in ECMO, when your patient's lungs are fibrosed, and because of post-COVID, the fibrosis is almost 60 to 80%, and you want to provide a oxygenation to the rest of the body, and just to avoiding a more damage to the positive pressure ventilation, or that is called VILI, ventilator induced lung injury. In that scenarios, you can go with the ECMO. There are different types of ECMO, VV ECMO, VA ECMO, okay, and you can go with that, and but the outcome are not so much encouraging of ECMO patients. But the COVID complications and the COVID fibrosis is a foremost indication to initiate an ECMO.
Okay, so there's another question. Patient on HFNC often complain of headache. Any treatment or cure?
Yeah, it's a very interesting question. Actually, the patients on HFNC is complaining headache because of oxygen toxicity. Okay, you are giving a 6 liter of flow to that patients, and you are not measuring the requirement of that patients, and your target, you always see कि हमारा saturation 100 रहना चाहिए, but our target should be 90 to 94, and you have to avoid hyperoxia. Because of that hyperoxia, your patient is complaining headache because of free radical toxicity. Okay, this is the only cause of headache when you are using HFNC.
So the message is that please don't target for 100% oxygen. 90 to 94% oxygen with a good monitoring is good. So that has to be kept in mind. So thank you, Dr. Rajesh. And before we move in to a very important session with Dr. Sarika Gupta, that is about arterial blood gas analysis. So which is very important and the most objective way for us to decide the upscalation or downscaling the oxygen therapy, non-invasive ventilation, or even ventilation. We would take a break of some 20 minutes and we would assemble here back. So we are now stopping at 1:42. A request to all of you to be back at 2 o'clock so that we can start our next presentation on arterial blood gas analysis. So a short break for all of you. Thank you.
So good afternoon, everyone. So after this short 20 minutes break post lunch, so this is topic RTA blood gas analysis. So I think I should start now. Everyone there and in awake state. So the topic is arterial blood gas analysis. So learning objective. So learning objective for RTA blood gas analysis chapter is, so we should know when it is indicated now, when we should do, who can do, the doctor, staff nurse or any trained medical person, and most important, how to do it and what is its clinical significance and what is the interpretation in context with the clinical condition. So these are the learning objective for this class. So what are indication to do arterial blood gas analysis? So any sick child who is coming to your ICU or to the emergency unit, arterial blood gas analysis need to be done to find out that this child who is presenting to you with respiratory distress, who is sick, so what is his or her oxygenation status, what is adequacy of ventilation, PCO2, what is acid-base balance, and another important role is that it document and monitor respiratory failure, especially during ventilation and oxygen therapy. So as you had read in the, you had been taught in previous two lectures that about oxygen therapy, about the ventilation, then when to give non-invasive, when to give the invasive ventilation, which kind of oxygen therapy to give at which time. So all these can be documented and monitored by the ABG, which will give us the value of the PO2 to decide about which kind of oxygen delivery device or the invasive or non-invasive ventilator need to be given. So first is sampling procedure, that how we are going to do this RTA blood gas analysis. So in this, most important first step is aseptic tipping, because we are puncturing an artery. So we will directly inject the infection into the circulatory system. So we must maintain the asepsis before doing the arterial blood gas analysis, before puncturing the artery and after completing the procedure. Then what are the equipments that are needed to do ABG analysis? So a needle, which can be either 23 or 25 gauge, or it can be even 24 gauge needle with 1 to 2 ml syringe. Pre-heparinized blood gas syringe, in which the collected blood is sent to the lab for ABG interpretation. Iodine swab for cleaning the local site. Dry cotton ball gauze piece to occlude the artery, and definitely blood gas lab request slip, on which you write down about the information about the patient's information, age, gender, name, and send to the lab for processing. Then, so what is the most common site to do the arterial blood gas analysis? So commonly we do radial artery almost always, but brachial artery and femoral artery can also be punctured to do the ABG analysis. Okay. So now tell me, you can text in the chat box. So before puncturing the radial artery, and ensuring the aseptic technique. What other thing you ensure before puncturing the radial artery? Anyone, please text in the chat box. So you had taken care of aseptic technique. You had pointed on the radial artery. What else will you check before puncturing the? Very good, Dr. Jitin. So it is the, and Dr. Rachit, it is the Allen test that need to be done prior to puncturing the radial artery. So we have to perform Allen test. Now, how this Allen test is being done? So everyone knows that we have to raise the hand of the patient, slightly extended the wrist, fixed banana hai, and we have to occlude both the radial artery and ulnar artery till the palm become the pale. So जब तक ये palm pale हो गया, हमको ये radial और ulnar artery को occlude करके रखना है, and then we will release the pressure on the ulnar artery. And if this palm again appear pink, so it suggests patency of the ulnar artery and the superficial palmar artery. So in that condition, we can puncture the radial artery. Otherwise, what happens if the agar wo on the releasing the pressure on ulnar artery, this palm is not appearing pink, it means that radial artery alone is supplying this palm area. So if we will puncture the radial artery, some thrombus is formed or it is occluded because of that thrombus, then blood supply to the palm will hamper and necrosis and gangrene can happen. So always perform Allen test prior to puncturing the radial artery. So after performing the Allen test, palpate the artery for the site of strongest arterial impulse. So again, it has been emphasized, it is how to do Allen test. So thumb occlude the radial and ulnar artery and pallor is produced by clenched fist. And while the pressure is continued on radial artery, it is released from ulnar artery. Unclench hand, return to baseline color because of patency of ulnar artery and the connecting superficial palmar artery. So this was the Allen test. So Allen test performed kar liya, it was okay. You had palpated the maximum impulse of the radial artery. Now at that point, you will inject the needle at the angle of 35 to 45 degree to puncture the radial artery. So procedure in detail. So scrub the site with solution iodine on cotton swab. Enter the skin at 30 to 45 degree angle, just proximal to wrist at about the level of proximal skin fold. Insert the needle gently but firmly in the area of maximal impulse. And जहाँ पे भी needle का जहाँ पे भी artery का maximum pressure मिल गया, आपने वहाँ पे gently but firmly needle को insert किया, and the needle is advanced slowly until the blood is obtained. क्योंकि जैसे ही आप puncture करोगे, if you are in the artery, blood will start coming flowing in the syringe. Or if you are not there in the artery, you will feel the resistance. So if the resistance is felt, what you have to do? Slowly withdraw the needle and direct the needle right or left to look for the artery. So advancement is changed slightly to one side and then to other to look for the artery. But if artery doesn't get punctured, even after redirecting several times, it would be better to withhold the procedure and withdraw the needle. So we have to learn the skill of doing ABG also, which I think everyone is knowing. So after the blood has been drawn, it is collected, a minimum of 0.2 ml blood is being collected in the pre-heparinized syringe. And again, an important step that you had withdrawn the needle and apply direct constant pressure for a minimum of 5 minutes, and it should be observed. ऐसा नहीं कि बस किया और उस पे लगाया कॉटन, अटेंडेंट को कहा कि ये लगा है देख लेना. No, you have to observe it that this pressure is being applied for at least 5 minutes because this is artery that is having pulsatile blood flow. So उसको blood flow रुकने में time लगेगा. So you have to be ensured, otherwise there can be serious blood loss to the patient. Okay. So when the blood has been collected in the pre-heparinized syringe, look for the presence of small bubble because the presence of these small bubble give the wrong value of oxygen and pH. Both of will be elevated. Like अगर patient को hypoxia है, आपने उस patient का blood ABG के लिए collect किया और pre-heparinized syringe में बहुत सारे gas bubbles हैं, so आपको pseudo normal oxygenation and normal pH की report मिल सकती है. So जितने भी गैस बबल्स होते हैं उनको ऐसे करके फ्लिक करके हटाने का होता है. Okay, after the blood has been collected properly, label the syringe with patient's information and take the sample immediately to the ABG lab after processing. क्योंकि अगर आपने निकाल दिया, सब अच्छे से निकाल दिया, आपने एसेप्सिस मेंटेन कर लिया, आपने एलन टेस्ट परफॉर्म कर लिया, अच्छे से पंक्चर कर लिया, आपने बबल्स का ख्याल रख लिया, आपने सैंपल को अच्छे से लेबल कर दिया और बस इतना कह दिया इसे ले जाओ, इसको जमा कराओ. तो पेशेंट के अटेंडेंट के पास तो बहुत सारे सैंपल पड़े हुए, उसको यहाँ कल्चर भी जमा करना है, उसको इलेक्ट्रोलाइट्स भी जमा करना है, सब जमा करना है. अब वो अकेला, उसको समझ नहीं आ रहा तो उसको लगे अच्छा ये वाला पास है, यहाँ कर ले या यहाँ दूर है, पहले उसको दिया है, व्हाटएवर, अपने कन्वीनियंट के हिसाब से. पर आपको ये बताना है कि सबसे पहले इसको जमा करना है, क्योंकि अगर विद इन 15 to 30 मिनट्स एबीजी सैंपल प्रोसेस नहीं हुआ, सो अगेन यू विल हैव फॉल्स वैल्यू, you will have decreased pH, you will have increased PCO2, you can have increased lactate because of the continuing metabolism being occurring in the blood cell. So this sample should be immediately processed. And take a record of date, time, site of puncture, any complications. So in this video is shown about the Allen test and how to do the procedure.
Needed for ABC, a 1 ml pre-paralyzed syringe, spirit and iodine swab, a microphone, and a requisition slips. With these things in hand, we now proceed to perform an ABG. First of all, we slightly extend the wrist of the patient. Then we clean it with a spirit swab, followed by a betadine swab. Then again by a spirit swab. Then we try to palpate the radial artery over the radius.
So Robinson will be, you want to cross
This video,
just say
Allen,
with the president. And
please mute yourself. So by these two videos, now it is clear how to do Allen test and how to draw the sample.
These are the things.
So what is the clinical significance of the ABG report? So any child who is presenting with acid-base imbalance will present with certain clinical signs. And when there is a sick, when the child is very sick, then it becomes difficult to demonstrate, find out what is the exact cause for this severity of the presentation. Like if the child is having arrhythmia, hypotension, pulmonary edema, hyperkalemia, or mental confusion, seizure, So electrolyte ABG report will give you a clue that what is the cause of this clinical worsening of the patient, whether it was the severe acidosis or it was severe alkalosis or any electrolyte imbalance or whatever. So we have to, so for clinical correlation and to find out what is the exact cause, ABG is needed. So it firmly established the severity of an oxygenation abnormality कि बच्चे का oxygenation थोड़ा सही कम है कि ज़्यादा कम है. So that can be find out by the looking at the value of the PO2. Then whether by looking at the PCO2 value in the ABG strip, we can find out that whether the child is hypoventilating or hyperventilating. Then it give information about the pH, about the bicarbonate, about the PCO2, so the acid-base status. Then if a child is on mechanical ventilation, whether the ventilation is the settings are proper or not, the child is responding or not, so we can track that by looking at the ABG value. So if the some setting has been done on mechanical ventilation and the patient ABG report is now coming towards normal, PO2 is improving, PCO2 is improving, metabolic acid-base status is improving, so that means the child is so these settings are appropriate, and the other clinical and other treatment are being given properly, so the ABG value is now returning to normal. And apart from acid-base status, oxygenation, ventilation, ABG also tells about the status of electrolyte, lactate, hematocrit, methemoglobin. All these values are also there. So ABG interpretation, it should be done by step-by-step approach. So as we learn alphabet, we learn A first, then we learn Z. So in ABG also, it should be a step-by-step approach. It should not be haphazard कि पहले ये value हमने आज मेरा मन किया ये पहले देख ले, आज इस value को पहले देख ले. No, it should be step-by-step. So although laboratory error has been written at the last, but lab error should be checked at the first, because as I said, that presence of gas bubbles or the time of the processing and all these things, stand machine has been standardized or not, these can affect the ABG values. So that could be checked. So when you had checked the lab errors, so the first value that is looked at the ABG is the pH. So make your vision tubular for the pH to be looked first on the ABG strip. So first we look at the pH in the ABG value. So when you had looked at the pH, then look at the respiratory and metabolic factors responsible for this pH. So क्या क्या होते हैं respiratory and metabolic factor? Can you text? Can anyone text what are those respiratory and metabolic factors which are on ABG to look who determine the status of pH? Very good. So it is bicarb, so metabolic, and respiratory क्या होता है? And what is and PCO2? Very good. So pH, pH जो भी है आपका normal या abnormal है, उसके लिए culprit या responsible person कौन है वो देखना होगा. और दो होते हैं, either it is PCO2 और bicarb और both. Okay. So ये दोनों देखने के बाद आपने देखा कि pH है वो गड़बड़ है, one of them is culprit. अब बॉडी में कुछ गड़बड़ हुआ, आपने culprit को भी find out कर लिया. अब शुरू में तो गड़बड़ी है, पर धीरे धीरे we go for the stage of compensation. जैसे कि कोविड शुरू हुआ तो पहले बहुत ही सब हौच पौच था, कुछ समझ नहीं आ रहा था, सब गड़बड़ी हो रहा था, पर धीरे धीरे we are adapting, we are in the winning stage कि हाँ हमें पता है कि अभी ऐसा हो जाए तो ऐसा करना है. ऐसे बॉडी भी कि जब pH गड़बड़ हुआ, कल्प्रिट पता चला, तो उसके बाद बॉडी कॉम्पेंसेट करती है. सो कॉम्पेंसेशन किससे होता है? इन्हीं दोनों से होता है. सो जिसने गड़बड़ किया उसका अपोजिट वाला कॉम्पेंसेट करता है. तो सबसे पहले pH देखना है, उसके बाद हमें PCO2 और बाइकार्ब की वैल्यू को देखना है, ये पता लगाने के लिए कल्प्रिट कौन है. और जब कल्प्रिट पता लगा लिया तो दूसरा फैक्टर होता है कॉम्पेंसेशन के लिए. सो वो कॉम्पेंसेट कर रहा है कि नहीं, स्टेज कौन सी स्टेज ऑफ कॉम्पेंसेशन है, सो वो देखना होगा. सो सबसे पहले में pH, बाइकार्ब और PCO2 देखना होता है. उसके बाद हम देखते हैं ऑक्सीजनेशन स्टेटस बाय लुकिंग एट द PO2 वैल्यू. Yes, Dr. Ayush, you are right. Acidosis or alkalosis depending on pH. Okay, so fourth is we look at the PO2 value. Then we find out whether this acid-base imbalance is a simple disorder or mixed disorder, like simple metabolic acidosis या respiratory alkalosis है या कोई mixed disorder है कि mixed respiratory acidosis and metabolic acidosis है. So we have to find out that by looking at the anion gap and by looking at the base deficit. Then we have to find out by looking at the by correlating with the clinical condition and by looking at the compensation whether the condition is acute or chronic. So remember that step-by-step approach of ABG interpretation always start with pH, bicarb, PCO2, then PO2. So you have to remember the normal values of all these parameters. So take the screenshot of this slide. So pH normal range is 7.35 to 7.45. If we have to take a single value, it is 7.4. So so we can say any value which is less than 7.4 will be acidotic. Any value which is more than 7.4 will be alkalotic. However, the range is 7.35 to 7.45. SaO2 that is the percent saturation of oxygenous hemoglobin जो कि हम pulse oximeter से भी check करते हैं. Normal range is 80 to 100%. PO2 that is the partial pressure of oxygen in arterial blood, value is 80 to 100 millimeter of mercury. PaCO2 partial pressure of carbon dioxide in arterial blood, normal range is 35 to 45 millimeter of mercury. Bicarb concentration is a normal range is 22 से 26 milliculant per liter. And base excess or base deficit, it is plus minus 2 milliculant per liter. So base excess of 2 or base deficit of 2 is normal. Anything above or below that will be abnormal. So remember these normal range. So this is the ABG strip. ऐसी आती है जो बहुत सारी वैल्यू होती है. हमको लगता है कि अच्छा लग सकता है कि हम अच्छा ठीक है जो पहली वैल्यू है उसी से लेके शुरू करें. नो, सबसे पहले हमें क्या देखना है? पीएच. सबसे पहले पेशेंट के इनिशियल हमने चेक कर लिया, टेम्परेचर, स्टैंडर्ड प्रेशर, वो सब चेक कर लिया. मशीन स्टैंडर्डाइज थी कि नहीं पता कर लिया, स्टैंडर्डाइजेशन प्रॉपर्ली हो रहा है कि नहीं. देन वी लुक एट द फर्स्ट वैल्यू इज द पीएच. आफ्टर लुकिंग एट पीएच वी लुक एट द PCO2 एंड bicarb. Bicarb कहाँ पे? So bicarb we look at the patient. Actual नहीं देखना, we have to look. Yes, sorry. So bicarb we have to look, and then we look at the PO2 value, and then we go to look for the base excess and anion gap, which is down anion gap. So first of all, we look at the pH. Then we look at the PCO2 bicarb, then we look at the PO2, SO2, and then base excess and anion gap. So these steps should always be remembered कि किस तरह में follow करना है. Okay. So हमने स्टेप पढ़े थे. सबसे पहले हमें क्या देखना था? पीएच. अब हमें नॉर्मल रेंज भी पता चल गई है पीएच की कि नॉर्मल रेंज 35 to 45 होती है. ओके. So any value which is less than 7.35 will be acidotic. Any value which will be more than 7.45 will be alkalotic. Okay. So हमने पीएच देखा. उसके बाद हम क्या देखने? PCO2 एंड bicarb. So इसके लिए तो कल्प्रिट कौन है वो उसको जानने के लिए हमें एक फॉर्मूला याद रखना है, या हमें इंडिया से निकल के रोम में चले जाना है. ROMS, रेस्पिरेटरी अपोजिट मेटाबॉलिक सेम. सो पीएच की गड़बड़ी जिस डायरेक्शन में होती है, अगर कल्प्रिट बाइकार्ब है तो बाइकार्ब भी हमें उसी डायरेक्शन में जाता हुआ दिखेगा. और अगर कल्प्रिट PCO2 है तो वो जो प्राइमरी एब्नॉर्मलिटी है उसकी अपोजिट डायरेक्शन में गया हुआ दिखेगा, जो कि हमें ये एरो से दिख रहा है. तो यहाँ पे क्या है? पीएच कम हुआ है, एरो डाउनवर्ड है. PCO2 का लेकिन लेवल क्या होना होगा? 40 से ज्यादा होना होगा, तभी तो वो एसिडोसिस कर पाएगा. सो PCO2 गोज इन अपोजिट डायरेक्शन, तो रेस्पिरेटरी अपोजिट. सो पीएच नीचे गया हुआ है, बाइकार्ब भी नीचे जाना पड़ेगा अगर ये मेटाबॉलिक एसिडोसिस है. सो सेम डायरेक्शन ऑफ पीएच, बाइकार्ब विल गो, opposite direction will go PCO2 for the acidosis or alkalosis. So ROMS, respiratory opposite metabolic 6. Again here alkalemia, pH बढ़ा हुआ है. अगर मेटाबॉलिक है तो हमें क्या समझ में आ जाना चाहिए कि बाइकार्ब बढ़ा हुआ होगा. अगर हम सोच रहे हैं कॉज रेस्पिरेटरी तो इसका क्या मतलब होगा एल्कलोसिस के लिए कि PCO2 कम होगा, अपोजिट डायरेक्शन. तो ROMS. So same formula ROMS. So now example, all of you please text answer in the chat box. So here pH is 7.25. हमने normal range क्या पढ़ी थी? 7.35 to 45 की पढ़ी थी. So ये pH क्या है? कम है. अब हमें किसको देखना था? PCO2 और बाइकार्ब को देखना था और हमें साथ में ROMS याद रखना था. So यहाँ पे PaCO2 कितना है? 50. Yes, yes, very good, very good. Yes. So PaCO2 is 50 and bicarb is 24. So PaCO2 की normal value कितनी थी? 35 to 45. So it's good. Post lunch इतने लोग सभी लोग जगे हुए हैं. Very good. And bicarb की value normal range थी 22 से 24. तो वो normal है. So हमने देखा कि pH abnormal है. PCO2 बढ़ा हुआ है. That is in opposite direction. पर एक को देख के खुश नहीं हो जाना है. पहले दूसरे को भी देख लेना है. Bicarb normal है. So it is respiratory acidosis. अभी हम स्टेप बाय स्टेप चल रहे हैं. अभी हम कंपेंसेशन की बात नहीं कर रहे. सो इनिशियल स्टेज में क्या होगा कि पीएच एबनॉर्मल होगा एंड वन ऑफ दीज टू वैल्यू विल बी एबनॉर्मल. सो ऑल ऑफ यू हैड रिटन राइटली. इट इज रेस्पिरेटरी एसिडोसिस. नेक्स्ट एग्जांपल, पीएच इज 7.56. सो रेंज से बढ़ा हुआ है. सो नाउ वी हैव टू लुक एट CO2 एंड बाइकार्ब. PaCO2 की नॉर्मल रेंज क्या होती है? 35 to 45. ये नॉर्मल दिख रहा है हमें. बाइकार्ब की वैल्यू होती है 22 से 24. ये बढ़ा हुआ है. सो ROMS respiratory opposite metabolic same. It is metabolic alkalosis. Very good. Everyone has written very rightly. Good. So it is metabolic alkalosis. So this stage is primary defect. यहाँ पे कि pH abnormal है और one of these CO2 or bicarb is abnormal, other value is normal. So it is the first stage, primary defect without any compensation. क्योंकि अभी बॉडी में सिर्फ गड़बड़ी हुई है, तुरंत compensation होने में थोड़ा तो टाइम लगेगा. वेरी गुड. सब अभी तक सब लोग अभी भी लिखते जा रहे हैं. गुड. So now look at the stages of compensation. So acute or uncompensated state as shown in the last slide, no time for compensation, pH and one of the parameter of PCO2 or bicarb will be abnormal. Then for normalization, some compensation will start in some time. So उसके लिए सबसे पहले आते हैं body buffer that act within minutes. Then came the respiratory within hours, and then came the renal system buffering that takes some days to start the compensation. So जब compensation की प्रक्रिया शुरू होती है, so first occur the stage of subacute or partially compensated state. So here still the compensation is not complete, and both the parameters will change in the same direction. So pH की गड़बड़ी हुई, culprit को पहचानने के लिए हमने ROMS का फॉर्मूला लगाया था. अब जो स्टेज ऑफ कॉम्पेंसेशन है, तो वो याद रखना है कि जब भी गड़बड़ी होगी, अगर हमें चीजें सॉर्ट आउट करनी है, तो दोनों को एक ही डायरेक्शन में चलना होगा. लड़ाई हुई, अब हमें कॉम्पेंसेट करना है, तो दोनों को एक ही डायरेक्शन में जाना होगा. अलग अलग डायरेक्शन में जाएंगे तो फिर से लड़ाई होगी. So at the stage of compensation, both CO2 and bicarb changes in the same direction. तो जिसने गड़बड़ी की होती है, कॉम्पेंसेशन के लिए दूसरा भी उसी डायरेक्शन में चला जाता है. जैसे कि अभी आपने जो सबसे पहला एग्जांपल देखा था रेस्पिरेटरी एसिडोसिस का, सो उसके कॉम्पेंसेशन में, तो रेस्पिरेटरी एसिडोसिस में क्या हुआ था? PCO2 बढ़ा हुआ था. तो उसके बढ़ा हुआ है, तो आंख बंद करके याद रखना है कि बढ़ा हुआ था, जो कल्प्रिट था वो बढ़ा हुआ था. सो कॉम्पेंसेशन पे दूसरा फैक्टर एक ही, बाइकार्ब, वो भी बढ़ जाएगा. सो लड़ाई बंद करनी है तो एक ही डायरेक्शन में जाना है. सो जिसने गड़बड़ी की थी उसी डायरेक्शन में चले जाओ तो कॉम्पेंसेशन हो जाएगा. सो बोथ द पैरामीटर गोज इन द सेम डायरेक्शन. फुली कॉम्पेंसेटेड स्टेट, तो यहाँ पे क्या होगा? pH will be near normal. I said so always remember that if there is some acid base imbalance in the body, pH will never return to normal, but it will go towards normal. जो normal range थी 7.35 to 45, उसी के आसपास की वैल्यू होगी. So pH will become near normal with abnormal value of PCO2 or bicarb. So वहाँ पे either of with ये PCO2 और bicarb की वैल्यू abnormal होगी. So कॉम्पेंसेशन कैसे होगा, वो भी कुछ लॉजिस्टिक फॉलो करता है और जो सेम डायरेक्शन में होता है, पर कैसे होगा? So if it is metabolic acidosis, so उसके compensation में predicted change in PCO2 is, इस slide की भी आप screenshot ले लेना अभी पूरा जब हो जाए. So predicted change in PCO2 is 1.5 into bicarb plus 8 plus minus 2. तो जितना भी change PCO2 का है वो इस formula से निकल आता है 1.5 into bicarb plus 8 plus minus 2. Yes, it is the right formula. So if patient PCO2 is roughly this value, his or her response is appropriate. If patient PCO2 is higher than this value, then they are failing to compensate adequately. Metabolic alkalosis. So every 10 millimeter, bicarb increases PCO2 by 7. Compensation by metabolic response. So in respiratory acidosis, for every 10 millimeter increase in PCO2, bicarb increases by 1 in acute condition and by 3 in chronic condition. So acute condition, like for example, if it is pneumonia, bicarb will increase by just 1, or if it is chronic condition like COPD, bicarb will increase by 3. If it is respiratory alkalosis, for every 10 millimeter decrease in PCO2, bicarb will decrease by 2 in acute and by 4 in chronic condition. So 1, 3 for respiratory acidosis, and 2 and 4 for respiratory alkalosis in acute and chronic condition respectively. We have to remember that. So take a screenshot for this slide also. So by this we can find out that compensation adequate hai ki nahi. Now again some examples, and please write your answer in the chat box. So here pH first pH is 7.25. 3.5 to 4.5 normal range hoti, it is decreased. PaCO2 37, it is normal. Bicarb is 21, normal value होती है 22 से 24, so it is decreased. Sorry, इसका पहले ही मैंने आपको बता दिया. So it is yes, you all have written rightly. It is metabolic acidosis. Okay. Another example, pH is 7.56, that is raised. Now we have to find out the culprit, ROMS. PaCO2 decreased है, so opposite direction of pH. Bicarb पहले उसको भी देख ले, normal है. So PaCO2 decreased है, bicarb normal है, pH बढ़ा हुआ. So it is respiratory alkalosis. It is clear to everyone. Dr. Sunil, you had written rightly. It is respiratory alkalosis. Okay. Now this example. Here pH is 7.50. So normal range 7.35 to 7.45. It is raised. Now apply the ROMS formula. So PCO2 is 51, but how? In the same direction of pH. So it doesn't look like as the primary abnormality. क्योंकि जो abnormality pH की होती है उसके opposite direction PCO2 जाता है अगर culprit होता है. Okay, अब हमने bicarb देखा, bicarb is 40, normal value होती है 22 से 24. It is बढ़ा हुआ. So ROMS के फॉर्मूला से हमें पता चल गया कि प्राइमरी कल्प्रिट कौन है यहाँ पे. Yes, Dr. Rita and Dr. Ayush, you had written rightly. Bicarb, very good. So it is metabolic alkalosis. अब हमें थर्ड स्टेज याद रखना है कि compensation. तो यहाँ पे जो कल्प्रिट था bicarb बढ़ा हुआ था. So अभी पैचअप करना है तो PCO2 को क्या करना होगा, बढ़ना होगा. So हमने देखा वैल्यू बढ़ी हुई है, 35 to 45 नॉर्मल रेंज थी, ये बढ़ी हुई है. But pH is not towards the normal, right? So very good. You all had written rightly. It is primary abnormality is metabolic alkalosis with compensation by respiratory acidosis, and it is partial compensation क्योंकि pH अभी towards normal नहीं है. Next example, pH is 7.30. So it is decreased, acidotic. Who is the culprit? ROMS. PaCO2 बढ़ा हुआ है 50, bicarb भी बढ़ा हुआ है 49. So by applying the ROMS formula, so which is the main culprit, PCO2 or bicarb for this decrease? Very good. So it is respiratory PCO2. Very good. So it is primary abnormality is respiratory acidosis. Of compensation to acidosis, the primary culprit was culprit was CO2. So जो पैचअप किसको करना है, bicarb को, और कैसे करना है कि जिस डायरेक्शन में कल्प्रिट गया है उसी डायरेक्शन में आप चले जाओ. तो आपने देखा कि bicarb में भी PCO2 की डायरेक्शन में चला गया. So what is the full answer, full interpretation for this value, for this No, it is not compensated metabolic with metabolic respiratory yes, so yes, written rightly. So Dr. Sarthak, Dr. Ayush. So it is primary abnormality is respiratory acidosis with partial compensation by metabolic alkalosis. So partially compensated respiratory acidosis. One more example. pH is 7.35, so just lower पे है, little bit decreased है. Okay, so इस decrease के लिए so pH to normal लग रहा है, तो normal पे क्या खुश हो जाना है हमें? नहीं, पहले हमें PCO2 और बाइकार्ब को देख लेना है. तो जब आपने देखा PCO2 और बाइकार्ब को, आपने देखा कि PCO2 की वैल्यू बढ़ी हुई है 49, नॉर्मल रेंज होती है 35 to 45, एंड बाइकार्ब भी बढ़ा हुआ है 30 है. अब ये pH 7.35 है, ऑल्दो ये नॉर्मल रेंज का लोअर लिमिट है, पर अगर हम जैसे मैंने बताया था कि एक वैल्यू ले लें 7.4, सो इट लुक्स लाइक एसिडिक. सो अगर ये एसिडिक है तो हमें फिर से ROMS लगाना है. सो रेस्पिरेटरी अपोजिट मेटाबॉलिक सेम. सो आपने क्या देखा कि बाइकार्ब तो बढ़ा हुआ है, PCO2 बढ़ा हुआ है, तो प्राइमरी कल्प्रिट इज रेस्पिरेटरी एसिडोसिस. ओके, तो हमें पता चल गया प्राइमरी कल्प्रिट PCO2 है. इसकी कॉम्पेंसेशन, थर्ड स्टेज हमें कॉम्पेंसेशन चेक करना है. तो आपने क्या देखा, PCO2 बढ़ा हुआ है, बाइकार्ब को कॉम्पेंसेट करना है, उसे भी बढ़ना हुआ होगा. आपने देखा बाइकार्ब भी बढ़ा हुआ है, तो यानी कॉम्पेंसेशन हो रहा है. अब आपने समझ गए कि ये जो pH टुवर्ड्स नॉर्मल है वो किस वजह से है. सो नाउ व्हाट इज योर फुल इंटरप्रिटेशन? No, it is not partially compensated. pH, look at the pH, it is towards normal. पिछला वाला था उसमें pH अभी भी 7.2 था, यहाँ पे pH नॉर्मल रेंज pH की क्या थी 7.35 to 45. So pH is towards normal with abnormal PCO2 and bicarb value. Yes, right. Dr. Shikha, it is fully compensated respiratory acidosis by metabolic alkalosis. So is it clear to everyone? If there any doubt, please text. So it is fully compensated respiratory acidosis. क्यों कह रहे हैं? सबसे पहले हमने क्या देखा, pH देखा, that is normal, लग रहा है normal, पर उस पर खुश नहीं होना है. पहले PCO2 बाइकार्ब को भी देख लेना है कि वो नॉर्मल है कि नहीं है. तो जब आपने देखा तो आपने पाया कि गड़बड़ है. सो गड़बड़ है तो आपको इस pH को लेना होगा एसिडिक. ठीक है, इट इज टुवर्ड्स नॉर्मल बट लोअर साइड में है, एंड दोनों की वैल्यू भी नॉर्मल नहीं है. सो देयर मस्ट बी सम डिफेक्ट. सो अगर ये वैल्यू 7.45 होती, अगर यहीं पे ये pH 7.45 होता तो हम उसे अल्कलोटिक मानते. तो एनी वैल्यू मोर देन 7.4 इज अल्कलोटिक, एनी वैल्यू लेस देन 7.4 इज acidotic. Thanks, Dr. Rita. So this is fully compensated respiratory acidosis क्योंकि pH normal है with abnormal PCO2 and bicarb value. Another example, pH 7.44, नॉर्मल रेंज में ही है 7.35 to 45. तो हम बहुत खुश हो गए कि pH नॉर्मल है, पर अभी खुश नहीं होना है. पहले सेकंड स्टेप पे तो आ जाए कि हमें PCO2 और बाइकार्ब की वैल्यू देखनी. तो PCO2 की नॉर्मल वैल्यू होती है 35 to 45, ये बढ़ा हुआ है. बाइकार्ब की वैल्यू होती है 22 से 24, ये बहुत ज्यादा बढ़ा हुआ है. सो यू विल टेक दिस pH which is less than 7.40. 7.40 is alkalotic. हमने इसको एल्कलोटिक माना. अब ROMS का फॉर्मूला अप्लाई किया. सो इसकी डायरेक्शन में दोनों ही जा रहे हैं. सो प्राइमरी कल्प्रिट विल बी बाइकार्ब क्योंकि रेस्पिरेटरी अपोजिट जाना होता है, मेटाबॉलिक को सेम डायरेक्शन में जाना होता है. सो इट लुक्स लाइक प्राइमरी एबनॉर्मलिटी. वेरी गुड. यस yes, Dr. Sunil and Dr. Rita rightly written. So it is metabolic alkalosis, right? अब थर्ड स्टेज कॉम्पेंसेशन. तो यहाँ पे बाइकार्ब बढ़ा हुआ है, उसने गड़बड़ किया, तो उसको कॉम्पेंसेट करने के लिए CO2 क्या करेगा, उसी की डायरेक्शन में चला जाएगा. दैट मीन्स कि वो भी बढ़ जाएगा. तो आप देख रहे हैं वो भी बढ़ा हुआ है, and pH is towards normal value. So it is fully compensated metabolic alkalosis with respiratory acidosis. So metabolic alkalosis with full compensation by respiratory acidosis. So is it clear to everyone? If anyone has doubt, please text. Okay. हमने पहला स्टेप समझ लिया पीएच, सेकंड स्टेप आरओएमएस समझ लिया कल्प्रिट को फाइंड आउट करने के लिए, और थर्ड स्टेज कॉम्पेंसेशन सेम डायरेक्शन में होगा वो। अब फोर्थ स्टेप क्या था, ऑक्सीजनेशन स्टेटस। ऑक्सीजनेशन स्टेटस के लिए वी लुक एट द PO2 एंड SpO2 वैल्यू। So it depends upon the age and inspired oxygen concentration. So normal value 80 से 100 होती है, but we have to remember कि newborn the range is 40 to 70 millimeter of mercury. अगर newborn में value 70 आ रही है तो आप ये नहीं कहोगे कि sorry it is hypoxia, कि newborn के लिए normal range PO2 की होती है 40 to 70 millimeter of mercury. On oxygen therapy, the value of PO2 will be high. It will be FiO2 5. तो जितना भी आपने FiO2 रखा हुआ है उसका 5 times usually PO2 होता है. Thank you. एंड ऑक्सीजनेशन के साथ हमें ये याद रखना है कि ऑक्सीजन ऐसा नहीं कि ऑक्सीजन 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 सिर्फ ऑक्सीजन देते नहीं रखना है हमें. इट शुड बी केप्ट एट अ मिनिमम लेवल जिसपे कि 80 to 100 का मेंटेन हो जाए टू अवॉइड टॉक्सिसिटी, बिकॉज किसी भी चीज की अधिकता भी नुकसान करती है. तो सेम अप्लाई फॉर ऑक्सीजन. सो ऑक्सीजन सप्लीमेंटेशन शुड बिलो 60% टू अवॉइड टॉक्सिसिटी. डेफिनेटली अगर ARDS है, बच्चा नहीं रिस्पॉन्ड कर रहा है तो आपको बढ़ाना पड़ेगा, बट अगर ये नॉर्मल रेंज मेंटेन है तो ट्राई टू कीप ऑक्सीजन सप्लीमेंटेशन बिलो 60%. Anemic patient will have normal PO2, SO2, but final delivery of oxygen to tissue will be compromised. And ABG also give information about the SpO2, which can also be measured by the pulse oximetry. Now, next step was simple or mixed disorder. आपने pH देख लिया, कल्प्रिट देख लिया, compensation देख लिया, oxygenation status देख लिया. अब आपको पता लगाना है कि ये simple disorder था जितना अभी तक देखा, या कुछ गड़बड़ी मिक्स डिसऑर्डर, यानी कि कोई थर्ड पर्सन भी आ गया है. तो जब भी थर्ड पर्सन आता है तो कॉम्पेंसेशन नहीं, एक डायरेक्शन में तो आप चल ही नहीं पाते, फिर तो सब पॉश पॉश होता है. सो इन सिंपल एसिड बेस्ड डिसऑर्डर बोथ PCO2 बाइकार्ब चेंजेस इन द सेम डायरेक्शन टू कॉम्पेंसेट, क्योंकि दो ही लोग हैं, दोनों ने अपना पैचअप कर लिया, पर जहां आ गया कोई तीसरा. सो इफ दे डू नॉट फॉलो दिस ट्रेंड कि गड़बड़ी हुई, कॉम्पेंसेशन में सेम डायरेक्शन में नहीं गए, सो ऑलवेज look for the presence of a third person. So a possibility of mixed disorder is likely. So the expected compensation for simple acid-base disorder is predetermined, जो कि मैंने अभी पहले पढ़ाया, आपने देखा कि सब सारे एग्जाम्पल से. So if they deviate from the normal, so आपको लग रहा है कि जो भी हमने अभी पढ़ा था उन सबसे कुछ अलग ही दिख रहा है, कि पढ़ाया गया था कि सेम डायरेक्शन में कॉम्पेंसेशन होगा, इतने से होगा कॉम्पेंसेशन, पर यहाँ तो कुछ फॉलो नहीं कर रहा है उस नॉर्मल को. So कोई तीसरा आ गया है. So there is possibility of mixed disorder. But before commenting that there is a possibility of mixed disorder, yes, clinical history is definitely very important, clinical correlation, and you must be confident in your mind that you know very well the ABG interpretation. Like जो ABG जिसमें pH normal था और आपने PCO2 बाइकार्ब देखा ही नहीं, तो हो सकता है कि आप इंटरप्रेट गलत कर लो कि हाँ नॉर्मल ABG. सो योर ABG स्किल इंटरप्रिटेशन स्किल शुड आल्सो बी वेरी परफेक्ट, एंड डेफिनेटली क्लिनिकल कोरिलेशन मस्ट बी देयर. ओके, सो बेसिकली मिक्स्ड डिसऑर्डर के लिए हम क्या क्या देखते हो, कहाँ जरूरी होता है, यूजुअली मेटाबॉलिक एसिडोसिस. सो वी लुक एट द एनायन गैप एंड बेस एक्सिस. एनायन गैप क्या होता है, सोडियम प्लस पोटेशियम माइनस क्लोराइड प्लस बाइकार्ब में नॉर्मल वैल्यू होती है 10 से 12. सो एनायन गैप अगर बढ़ा होगा, सो इट गिव्स यू इंफॉर्मेशन अबाउट द अनबेस्ड एनायंस. Base excess or deficit, it is in between plus minus 2. So anything less than minus 2 or anything more than plus 2, it suggests that some anions, some unmeasured anions are there. So here in this example, pH is 6.98, 7.35 to 4.5 की रेंज थी, तो बहुत ज्यादा एसिडोटिक है. Now कल्प्रिट हमें पता करना है, तो हमें ROMS का फॉर्मूला लगाना है. So PCO2 goes in opposite direction. Okay, 62 बढ़ा हुआ है, दिख रहा है. बाइकार्ब 14 है, वो अपोजिट डायरेक्शन में. तो यहाँ तो दोनों ही फॉर्मूला लग रहे हैं, ROMS रेस्पिरेटरी अपोजिट, मेटाबॉलिक सेम. अब हमें पता ही नहीं कि कौन प्राइमरी कल्प्रिट है, कॉम्पेंसेशन हो भी रहा है कि नहीं हो रहा है, क्योंकि कॉम्पेंसेशन में बताया गया था कि सेम डायरेक्शन में जाएंगे, यहाँ पे उल्टी डायरेक्शन में जा रहे हैं. पीएच भी गड़बड़ है तो क्या ये पार्शली कॉम्पेंसेटेड है, क्या हो रहा है समझ नहीं आ रहा है, ठीक है। सो बेसिकली फर्स्ट और सेकंड स्टेप पे अभी हम देखें, सो पीएच इज एसिडोटिक एंड बोथ आर लुकिंग एज कल्प्रिट by applying the ROMS formula, respiratory opposite metabolic change. So respiratory acidosis भी लग रही है और metabolic acidosis भी लग रही है, okay. Next step SpO2 90%. So it is hypoxia नहीं, 80 to 100 का रेंज होता है, it is normal. आपने जब बेस एक्सेस देखा, it is -11. So unmeasured anions are there and anion gap is बढ़ा हुआ 18. So here respiratory acidosis भी है, साथ में metabolic acidosis है because of some unmeasured anion. So this ABG strip is an example of a mixed disorder, जहाँ पे कि normal जो आपने formulae लगाए और compensation का direction समझा था वो यहाँ पे fit ही नहीं हो रहा है, and base excess and anion gaps are abnormal. So it is mixed disorder. So here it is respiratory acidosis mixed with metabolic acidosis. So one question, and Dr. Sathik, as you said that clinical history is important, so apply clinical history here also. A 6-year male child presenting to emergency with complaint of fever, abnormal body movement for 2 days. So what is clinical diagnosis? Just on the basis of this, fever and abnormal body movement for 2 days. So what do you expect that ABG can show you? What abnormality? Please text anyone. Alkalosis. Okay, very good, because it is fever, abnormal body movement, looks like AES. So there can be increased respiratory effort, so it can be respiratory alkalosis. Metabolic alkalosis will no, metabolic alkalosis होने के लिए either some loss will be there. Okay. Okay, alkalosis respiratory is more likely. Okay, so ABG is this. pH is 7 point, yes, electrolyte imbalance can also be there, very good. So pH is 7.39, PCO2 is 40, PO2 is 74.5, bicarb is 22.1, and base excess is -0.8. So please write your interpretation for this ABG value, going step by step. जो मैंने सिखाया है pH, then look at the PCO2 and bicarb value, then आगे के steps. So what is your interpretation for this ABG strip? ABG finding. Anyone? Normal. Dr. Abhishek ने लिखा. Okay. Anyone else? Okay. So first step था pH देखना. pH was 7 point. Very good. So Dr. Sunil has written rightly. It is hypoxia with normal ABG, normal acid base. It is very good. So सबसे पहले आपने pH देखा. So pH is 7.39. Normal range में है 7.35 to 45. Okay. पर अभी से pH पे खुश नहीं होना है, क्योंकि अगर fully compensated भी होगा तो भी pH towards normal हो सकता है. So PCO2 bicarb को पहले देखिए. PCO2 is 40. Normal range कितनी होती है? 35 to 45. It is normal. बाइकार्ब का कितना नॉर्मल वैल्यू होता है? 22 से 24. इट इज आल्सो नॉर्मल. तो पीएच नॉर्मल है, पीसीओ2 नॉर्मल है, बाइकार्ब नॉर्मल है. फोर्थ स्टेप क्या था? पीओ2 देखिए. सो ये 74.5 है. नॉर्मल रेंज क्या होती है? 80 to 100. सो इट इज हाइपोक्सिया and base excess +-2 is normal, so it is +-0.8, so it is normal. So इस ABG strip में सिर्फ एक ही चीज गड़बड़ है, that is hypoxia with normal acid base state. So it was right by Dr. Sunil that it is, and one more doctor का नाम हमें पूरा नहीं दिख रहा है. Dr. Sunil के पहले जिन्होंने लिखा है, it is normal. Dr. Abhishek, normal but with acid base status normal. So पूरा sorry normal नहीं है, it is hypoxia with normal ABG. तो ये पूरा लिखना पड़ेगा. So Dr. Sunil has written rightly. Next, a 6-year-old child came with fever for 5 days and rapid breathing since today morning. ABG reveals the following. What is your interpretation? So fever for 5 days and rapid breathing since today morning. PO2. So yes, आप इंटरप्रिटेशन बताओ. So सबसे पहले में क्या देखना होता है? सबसे पहले देखना होगा pH 7.30. उसके बाद देखेंगे PCO2 और बाइकार्ब. PCO2 is 63, बाइकार्ब is 29. PO2 is 68.2 and base excess is +4. So what is interpretation? Respiratory acidosis, compensated hypoxia. Another respiratory acidosis with hypoxia. Okay. So सबसे पहले आपने pH देखा. pH looks like acidotic क्योंकि लिखा ही हुआ है कि normal रेंज थी acidotic. अब हमें ROMS देखना है. PCO2 इन बाइकार्ब की वैल्यू को देखना है. So PCO2 बढ़ा हुआ है. It is 63. So it may be respiratory acidosis, but first look at the bicarb also. It is 29. So little bit increased. So primary culprit समझ में आ गया ROMS से कि it is respiratory acidosis बढ़ा हुआ है. bicarb को भी बढ़ा हुआ होना होगा. bicarb बढ़ा हुआ है, पर pH अभी towards normal नहीं हुआ है. So it is partially compensated respiratory acidosis. Okay. फिर आप PO2 पे गए. That is 68. So hypoxia is also there. Okay. और जब आपने बेस एक्सेस देखा, so आपने देखा कि एनायंस दो बढ़े हुए हैं, दो एक्स्ट्रा कैटायंस हैं. So there is a base excess of +2, right? So it is partially compensated. So it is respiratory acidosis with partial metabolic compensation. Always option में hypoxia पे comment नहीं है, but you पूरा यही होगा कि it is partially compensated respiratory acidosis with hypoxia with a base excess of 2, right? So this is the whole interpretation for this ABG. Okay. So what are the common problem that leads to mixed disturbance? So basically जितनी भी common problem है, they are potential for mixed disturbance. Acute severe eczema, shock, cardiopulmonary arrest, respiratory distress syndrome in newborn, diarrhea with vomiting, decompensated liver disease, diuretic therapy, salicylate poisoning, all can contribute to mixed disturbance. So you must know the step-by-step interpretation of APG. Examples, some more. So first example of it is सबसे पहले clinical correlation important है. So asthma patient. pH is 7.6, 7.35 to 45 range normal होती है, so it is alkalotic. अब ROMS, which is the culprit, so respiratory opposite, metabolic same. So आपने देखा कि PCO2 घटा हुआ है, that is it is going in opposite direction of the pH, respiratory opposite. मैं पहले bicarb भी देख लें. So bicarb is normal, so it is respiratory alkalosis. Okay. Then you looked at PO2. It is 65. Normal range होती है 80 to 100. So it is uncompensated respiratory alkalosis with mild hypoxemia. So correct. First example is clear to everyone. If any doubt, please text. Second example, a case of diarrhea. So pH is 7.24. Normal range 3.5 to 4.5. So it is acidotic. So pH is acidotic. Now ROMS, respiratory opposite, metabolic same. So pH घटा हुआ है, respiratory opposite. अगर ये respiratory pathology होती तो PCO2 बढ़ा हुआ, तो आपने देखा कि that is just lower range of normal. So respiratory culprit नहीं लग रहा. bicarb metabolic same, तो घटा हुआ है. So primary abnormality is metabolic alkalosis. अब उसके compensation में PCO2 को भी घटा हुआ होना चाहिए. तो PCO2 अभी घट रहा है, लेकिन उतना पूरा नहीं घटा है. And pH is still abnormal. So it looks like partially compensated metabolic alkalosis, or you can say, ठीक है. And PO2 is not 90. So PO2 is normal. So it is partially compensated metabolic acidosis without hypoxemia. Third example, a case of muscle weakness. Polio तब दिखता नहीं है, so it can be GBS or something other. So pH is 7.20. Acidotic. Who is the culprit? So respiratory opposite, metabolic same. So PCO2 बढ़ा हुआ है क्योंकि normal range 35 से 45 होती है. bicarb 22 से 24 normal range होती है. तो आप देख रहे हो कि PCO2 बढ़ा हुआ भी है and bicarb घटा हुआ भी है. So you are in fix कि कौन primary abnormality है इसके लिए. क्योंकि रेस्पिरेटरी अपोजिट भी है और मेटाबॉलिक सेम डायरेक्शन में भी गया हुआ है. सो इट कैन बी अ मिक्स्ड डिसऑर्डर and PO2 was 50 hypoxemia. So it is acidosis. I will not say it is uncompensated respiratory acidosis क्योंकि बाइकार्ब भी घटा हुआ है. बाइकार्ब को बढ़ा हुआ होना चाहिए, नॉर्मल होता. अगर ये 22 होता देन वी कैन से इट इज अनकॉम्पेंसेटेड रेस्पिरेटरी एसिडोसिस विद हाइपोक्सीमिया, क्योंकि बाइकार्ब की नॉर्मल वैल्यू 22 से 24 होती है. Another example, vomiting. pH is 7.44. So it is normal, looks like normal. But first we have to check that whether CO2 and bicarb are normal or not. So PCO2 is बढ़ा हुआ, okay, 35 to 45 range होती है, and bicarb is बढ़ा हुआ. So PCO2 बढ़ा हुआ है, PCO2 बढ़ता है तो एसिडोसिस होती है, तो pH एसिडोटिक तो नहीं लग रहा है. ठीक है. सो ये ऑलरेडी टुवर्ड्स नॉर्मल है बट एल्कलाइन साइड में, एंड बाइकार्ब इज आल्सो बढ़ा हुआ. सो इट लुक्स लाइक दैट मेटाबॉलिक एल्कलोसिस वाज देयर. सो मेटाबॉलिक एल्कलोसिस, बाइकार्ब बढ़ा हुआ, कॉम्पेंसेशन के लिए CO2 सेम डायरेक्शन में जाएगा, वो भी बढ़ा हुआ, एंड pH इज टुवर्ड्स नॉर्मल. So pH normal with abnormal PCO2 and bicarb value. So it is fully compensated metabolic alkalosis, and PO2 is normal. So it is fully compensated metabolic alkalosis with no hypoxemia. Fifth example, respiratory distress syndrome. pH is 7.12, acidotic, ROMS. So PCO2 घटा हुआ है, तो PCO2 तो नहीं लग रहा है कल्प्रिट. MS लगाया, बाइकार्ब घटा हुआ है, so main culprit is metabolic acidosis. So ये घटा हुआ है, उसके compensation में बाइकार्ब को भी घटा हुआ, बाइकार्ब घटा हुआ, उसके compensation में PCO2 को भी घटा हुआ होना होगा compensate करने के लिए, तो वो जा रहा है decreasing direction में, पर अभी पूरा नहीं हुआ है क्योंकि pH अभी भी abnormal है. So it looks like metabolic alkalosis with partial compensation, and PO2 is 30. So ये 30 क्या हुआ, न्यूबॉर्न में रेंज होती है 40 to 70. So it is hypoxemia. So it is partially compensated metabolic acidosis with severe hypoxemia. So take home messages are, so now you are clear that how ABG will play a role in a critically ill child to decide about what is the primary abnormality. And in mixed disorder, we have to look for some other extra factor, third factor. So knowledge of ABG is essential for any physician who handles a critically ill child. And the skills that need to be enhanced for ABG interpretations are that maintain strict asepsis and hand hygiene, most important, site localization, then definitely Allen test performance, proper technique of sampling and proper correct collection of sample. Then after the procedure has been done, all the cotton swab, syringes, they all should be disposed of in proper bins, red, yellow, black. Use PP as appropriate. And most important, enhance your interpretation skill with practice. So read more and more ABG strip to enhance your skill. So thank you all. So any questions? So please text on your question. So for sharing the PDF, Dr. Chandrakanta will answer.
So Sarika, they will get a link for PDF along with their e-certificate after completion of the training.
Okay, ma'am. Okay, so if there is no question, so I will like to invite Dr. Saksham from Integral College Lucknow for his class on discharge policy and post-COVID care. So over to you, Dr. Saksham.
Yes, ma'am. Am I audible?
Yes, you are audible.
Okay. I'm sharing my screen.
Yes.
Is my screen visible to you all?
Yes, your screen is visible. visible.
So, good afternoon to everyone. Now, the topic right now we are dealing is discharge policy and post-COVID care of adolescents and children. Now, what will be the learning goals of this presentation? We'll be knowing about the discharge policy, that is the criteria for discharge, then home care after discharge, and post-COVID care in the immediate discharge period. Now, how do we define asymptomatic cases? Asymptomatic admitted only if home isolation is not possible, they will be admitted. In those cases, like they don't have a separate room or separate toilet, for those patients, they will be discharged on day 10 after the test was positive, or day 7 of admission, whichever is later. No repeat testing is required, and there will be mandatory home isolation for 7 days after discharge. In mild category cases, they will be admitted only if, again, there is no possibility of home isolation, that is no separate room or no separate toilet. The discharge criteria for these population or these patients are, that is again day 10 after the test was positive, or day 7 of admission, whichever is later. Again, in this category, there is no need for repeat testing, and same as mandatory home isolation for 7 days after discharge. For moderate category cases, they will be discharged when the patient does not need supplemental oxygen and is asymptomatic or has mild symptoms and repeat test is negative, after thorough examination by the treating doctor with proper advice about monitoring of respiratory rate, oxygen saturation and temperature at home. Now, in severe category cases, those who required ICU admission till intensive care is needed, they should be shifted to downward, like in HDU or in the ward after from HDU. Then they will be discharged when the patient does not need supplemental oxygen and is asymptomatic or is mildly symptomatic. Again, the repeat test is negative, after thorough examination by the treating doctor with proper advice about monitoring of respiratory rate, oxygen saturation and temperature. Now, the advice on discharge at home will be required for all the categories. Mandatory home isolation for minimum 7 days after discharge. Use of mask for prevention of infection to other family members and society. Hand hygiene. Clothes used in hospital to be disinfected by hydrogen peroxide, sodium hypochlorite. Now, disinfection of the mobile phones, footwear, other things which were used in the hospital with alcohol-based hand rub or hydrogen peroxide. Clothes worn at time of discharge to be washed with hot water and detergent. Patient and parent to sign a declaration to follow home isolation and other precautions. They should be monitoring the symptoms. If needed, report to COVID care center or call the COVID helpline. Now, post-COVID care in immediate period after recovery from COVID, it's a holistic approach should be followed. Recovery period may be longer in patients with moderate and severe symptoms and those with comorbidities. They should be following appropriate COVID behavior like hand hygiene, respiratory hygiene, social distancing. The children should be kept well hydrated. They should resume pre-COVID activities gradually. Immunity promoting medicines should be given. Mild exercises and games. Nutritious, fresh food, fresh home cooked food should be given. Adequate rest and sleep. Regular medications as per the prescription given by the doctor or required for any pre-existing illnesses should be followed. Monitoring of symptoms or danger signs by the parents or the caregiver. Now, what are the danger signs or early warning signs? They should be, they are breathlessness, fever, falling saturation below 94%. So that's why temperature monitoring should be mandatory and should be done regularly. If a diabetic child, then blood sugar monitoring should also be done. And again, saturation is monitored. If there is symptoms like cough, sore throat, medicines like gargles can be prescribed, cough medications can be given, and steam inhalation can be given. Now at community level, they should seek psychosocial help from peers and self-help groups and counselors, mental health support services, parents of recovered children, recovered adolescents to share their positive experiences with others in the family and society, create awareness, dispel myths and stigma. For asymptomatic and mild for asymptomatic patients, follow-up visit at healthcare facility from where discharged or previous doctor should be after 7 days. For moderate and severe category cases, there should be more stringent follow-up and should be there within 7 days post-discharge, and to contact nearest healthcare facility in case of development of any danger signs or symptoms. Thank you. Now over to you, Dr. Sarika.
Thank you, Dr. Sakshu. So now the last topic for today, it will be taken by Dr. Anupma on the care of the deceased. So over to you, Dr. Anupma, and I'm very happy to invite Dr. Anupma. She's our resident and now she's faculty at LLR Merit. Over to you, Dr. Anupma.
Thank you, ma'am. Thank you.
Any problem, Dr. Anupma?
No, ma'am. I'm sharing. Ma'am, is my screen visible?
Yes, your screen is visible.
Okay, ma'am. Good afternoon, everyone. For the next 20 minutes, I will be talking about management of disease. This is not a happy topic, but it is very important to know about it. अपनी सेफ्टी के लिए, अपनी नर्सिंग स्टाफ की सेफ्टी के लिए, आपके जो 4th क्लास एम्प्लॉय हैं साथ में जो काम कर रहे हैं उनकी सेफ्टी के लिए, it is very important to know the management of the disease. All my slides are based on the guidelines which is issued by the Ministry of Family Welfare in the month of March 15, 2020. Some numbers: laboratory confirmed cases are 2.74 crores, deaths are around 3.15 lakhs, and third wave of the disease is expected to come in another few weeks, and pediatric age group is likely to be affected. Hope ये सब कुछ भी ना हो. Knowledge gap is how to dispose of dead body of a suspect or a confirmed case of COVID-19. All staff should be which are handling the dead bodies in the isolation area or in mortuary area, ambulance, and those workers in the crematorium and burial ground should be trained in the infection prevention control practices. Some key facts: the main driver of transmission of COVID-19 is through droplets. We all know it. COVID-19 spreads by the droplet infection. And so it is very unlikely that there is an increased risk of COVID infection from a dead body to healthcare workers or family members who follow standard precautions by handling the body. Only the lung of a dead COVID patient is infectious. So it should be handled with care during if an autopsy is done in the COVID patients. Skills to be enhanced are hand hygiene, use of personal protective equipment, and appropriate disinfection. ये 3 पॉइंट्स हैं और की पॉइंट्स हैं, ये बार बार आएंगे, ये बिल्कुल हमारे अंदर ड्रिल हो जाने चाहिए. हैंड हाइजीन, पीपीई का यूज और एप्रोप्रिएट डिसइंफेक्शन. एंड व्हाट शुड बी आवर स्टैंडर्ड प्रिकॉशंस? फर्स्ट, हैंड हाइजीन, यूज ऑफ पीपीई. पीपीई में क्या क्या आएगा? वाटर रेजिस्टेंट एप्रन, ग्लव्स, मास्क एंड आई वेयर. There should be safe handling of sharps, disinfectant bag housing dead bodies, instrument, devices used in the patient, disinfect linen, जितने भी linen है, environmental surfaces है, which can be a potent carrier of COVID-19 transmission, should be cleaned properly. First of all, what should we know? How to remove the body from an isolation. जहाँ पे भी death हुई है patient की, उसके बाद उस body को move करना है आपको from isolation area to either to the mortuary or it should be handed over to the attendant. तो उससे पहले क्या क्या हम लोगों को एक ना वो होना चाहिए कि first of all hand hygiene बार बार आएगा. Hand hygiene is very important and it is one of the most important step to prevent transmission. We should ensure proper use of PPE. PPE में water resistant apron है, goggles हैं, N95 mask है, gloves हैं. One important point, all tube, drains, catheters, जो भी body में आपकी patient में है, it should be removed before zipping the bag into the this bag, body bag में. Body bag में डालने से पहले जितने भी tube, drains, catheters हैं, वो हमें निकालने हैं. और जो भी punctures, holes और wounds हैं, and it should be disinfectant with 70% alcohol or 1% sodium hypochlorite solution and dressed with impermeable material. बॉडी को पैक करने से पहले ये बिल्कुल इंश्योर कर लेना है किसी भी साइड से ओजिंग ऑफ फ्लूइड नहीं होना चाहिए. दैट कैन बी अ पोटेंट सोर्स ऑफ एनी काइंड ऑफ इन्फेक्शन. तो ये इंपॉर्टेंट है. जितना भी ड्रेन कैथेटर है वो हटाने हैं. जो भी ओजिंग साइड्स हैं आपको उन्हें क्लोज करना है विद द इम्पर्मिएबल मटेरियल. अप्लाई कॉशन व्हाइल हैंडलिंग शार्प इंस्ट्रूमेंट्स such as intravenous catheter, other sharp devices, they should be disposed into sharp containers. जितने भी sharp instrument हैं, जैसे भी हम और normal protocols में रहता है, sharp container में dispose करने हैं. We should plug oral nasal orifice of the dead patient to prevent leakage of body fluid. Same, कहीं से भी body fluid नहीं होना चाहिए patient का. And if the family of a patient wishes to view the body at the time of removal from an isolation area, they should be allowed to do so. We should always respect the sentiments of the family. बहुत ही मतलब we should try to support the family. और जो भी desires हैं patient के, अगर वो breach नहीं करते हमारे precautions method में, तो we should allow them. We should place the dead body in a leak-proof zip plastic body bag immediately after the death with the identification tag, which is very important. मतलब कि कोई आगे इसकी वजह से unnecessary प्रॉब्लम ना हो. आइडेंटिफिकेशन टैग इज वेरी इंपॉर्टेंट. कि जब भी पेशेंट को आप बॉडी बैग में प्लेस करेंगे तो दो चीज इंपॉर्टेंट है. एक तो कोविड-19 पर मार्क होना चाहिए उसके ऊपर. दूसरा आइडेंटिफाई को कंफर्म करके आइडेंटिफिकेशन टैग होना चाहिए बॉडी पे. बॉडी को पैक कर दिया क्योंकि आपने सारा सब होल्स सब प्लग कर दिए. जितना भी फ्लूइड था वो आपने इम्पर्मेबल से सील कर दिया. अब इम्पोर्टेंट क्या है? द एक्सटीरियर ऑफ द बॉडी बैग का बाहर वाला पार्ट, इट शुड बी डिकंटामिनेटेड विद 1% हाइपोक्लोराइड. उसे भी हम अगर 1% ये है कि उसमें भी कुछ सोर्स ऑफ इन्फेक्शन, तो आपने बाहर वाला सरफेस है उसको भी क्लीन कर दिया विद 1% सोडियम हाइपोक्लोराइड. The body should be fully sealed in an impermeable body bag before being transported from an isolation room. ये important है. और शीट, कई बार क्या होता है, शीट फैमिली प्रोवाइड करती है कि उन्हें बॉडी के साथ रखना है, तो वी शुड रिस्पेक्ट इट. और वो शीट हम बैग के ऊपर रैप कर सकते हैं पेशेंट के. द बॉडी विल बी आइदर हैंडेड ओवर टू द रिलेटिव्स और टेकन टू द मॉर्चरी एज अर्ली एज पॉसिबल. तो या तो रिलेटिव्स को हैंड हो जाएगी या वो मॉर्चरी जाएगी. बीच में आपका वो नहीं होना चाहिए ना कि इधर उधर टाइम वेस्ट नहीं करना चाहिए. either it should be handed to the relatives or it should be sent to mortuary. All used soil linen should be handled with standard precautions, put in biohazard bag, and outer surface of bag should be disinfected with hypochlorite solution. आपने बॉडी पैक कर दी, उसके बाद हमारा काम क्या बचा? उस आइसोलेशन रूम में आपके इक्विपमेंट है, आपका मेडिकल वेस्ट है, आपका सरफेसेस हैं, तो उनको भी आपको क्लीन करना है. दैट कैन आल्सो बी अ सोर्स ऑफ इन्फेक्शन. यूज्ड इक्विपमेंट शुड बी ऑटोक्लेव और डिकंटामिनेटेड विद डिसइंफेक्टेंट सॉल्यूशन in accordance with the established infection prevention control practices. All medical waste should be handled and disposed of in accordance with the biomedical waste management guidelines. The health staff who handle the body will remove, आप उसके बाद PPE हटानी है, should remove the PPE and will perform the hand hygiene. We should provide counseling to the family members and respect their sentiment. It is very important. आप चाहे कितने busy हो, आपके पास चाहे कितना ही patient load हो, पर we should have some time, at least 5 to 10 minutes for the family. उनसे बात करनी है, उनकी जो queries हैं वो solve करनी है, and we should give consoling words to them. So that is also very important. Next, environmental cleaning and disinfection. All the surfaces of an isolation, चाहे आपका floor है, bed है, railings है, IV stands है, all should be wiped with 1% sodium hypochlorite solution. Contact time should be 30 minutes. उसके बाद air dry के लिए छोड़ देना है उसे. Allowed to be air dry. अब mortuary में क्या करना है? Handling of dead body in mortuary. Mortuary must be kept clean. Mortuary staff should be observed and they should follow all the standard precautions. Dead body should be stored at the temperature of 4 degrees centigrade, and all the environmental surfaces, instrument, transport trolley should be disinfected with 1% hypochlorite solution. ये 1% hypochlorite solution हर है, जहाँ पे भी आपको cleaning है, सारे surfaces की है, आपके IV stands हैं, body का exterior part है, उन सब की cleaning हमें 1% hypochlorite solution से करनी है. After removing the body, the chamber doors, handles, floors, ये भी potent source हैं, क्योंकि ट्रांसमिशन के चांसेस बढ़ जाते हैं इससे, तो that should also be cleaned with sodium hypochlorite solution. Ambling of dead body should not be allowed in COVID patients. Autopsies should be avoided, but if it is done for special reason. The following infection prevention control practices should be adopted. First, क्या important रखना autopsy करते टाइम? Negative pressure होना चाहिए mortuary में. Team जो autopsy करने जा रही है, it should be well trained in infection prevention and control practices, and number of the forensic expert जो भी autopsy कर रहे हैं, that should be limited, and the team should fully complement of PPE. यहाँ पे PPE का मतलब क्या है? पूरा overall. इसमें head cover भी आएगा, shoe cover भी आएगा, N95 mask, goggles and face shield. So that is the PPE. That PPE should be used for the autopsy. सेकेंड इंपॉर्टेंट पॉइंट क्या रखना है? एक तो टेम्परेचर मेंटेन करना है, क्लीन रखनी है हमें. दूसरा है कि हमें ना शार्प इंस्ट्रूमेंट्स को अवॉइड करना है, जस्ट टू अवॉइड द प्रिक इंजुरीज अवॉइड करने के लिए. तो इसीलिए ही राउंड एंडेड सीजर्स शुड बी यूज्ड. PM40 और एनी अदर हैवी ड्यूटी ब्लेड्स विद ब्लंटेड पॉइंट्स, जिनके ब्लंटेड पॉइंट्स होते हैं, दैट शुड बी यूज्ड just to avoid prick injuries. Only one body cavity at a time should be dissected. And unfixed organ, जो भी unfixed organs हैं, basically उनमें ये है कि आप slice करते टाइम आप अपनी इंजुरी ना करते, तो उसे हमेशा टेबल पे प्लेस करना है. Then it should be slide with a sponge, and care should be taken to protect your hand. An oscillator saw of with suction extraction of bone aerosol, क्योंकि उस टाइम कटिंग के थ्रू बोन को जब भी कट करेंगे तो एरिसोल्स जनरेट करेंगे होंगे, तो ideally it should be used with suction extraction, and bone aerosol into a removable chamber should be used for the sawing of skull. Otherwise, a hand saw with a chain mail glove may be used. Needle should not be resheathed. It should be placed in sharp. जो हमने पहले पढ़ा, जितने भी sharp instrument है, sharp instrument bucket जो है, उसमें place करना है सारा. We should reduce aerosol generation during autopsy using appropriate technique, especially while handling lung tissue, क्योंकि lung tissue ही infected part है जो infection कर सकता है. तो lung tissue को जब भी handle कर रहे हैं, we should use the technique which should reduce the aerosol generation. After the procedure, body should be disinfected with 1% sodium hypochlorite and placed in a body bag. Again, the exterior of the body bag should be decontaminated with 1% sodium hypochlorite. The body thereafter can be handed over to the relative. An autopsy table should be disinfected as per the standard protocols. Now the transportation. ट्रांसपोर्टेशन में अगर अभी तक के आपने स्टेप सारे अच्छे से फॉलो करे हैं, आपने पीपी यूज किए हैं, हैंड हाइजीन मेंटेन करी है, बॉडी को अच्छे से क्या कहते हैं बॉडी बैग में प्लेस किया है, इसके अगर अभी तक के स्टेप्स हैं, तो अब जो बॉडी है, बॉडी बैग है, एक्सटीरियर सरफेस है, इट पोजेस नो एडिशनल रिस्क टू द स्टाफ ट्रांसपोर्टिंग द डेड बॉडीज. तो ये चीज ना कम्युनिकेट भी करनी चाहिए हमें, जो स्टाफ उसमें इन्वॉल्व है ट्रांसपोर्टेशन में, कि अब एडिशनल रिस्क कुछ भी नहीं है फ्रॉम द बॉडी टू द staff members. The personal handling the body may follow the standard precautions. अब सिर्फ जो standard precautions में mask और gloves आएगा, अब पीपी का रोल नहीं है, सिर्फ मास्क लगाता है अगर हमारा स्टाफ और gloves यूज करता है तो that is more than sufficient. The vehicle after the transfer of the body to the cremation or the burial ground will be decontaminated. जैसे आपने सारी surfaces clean करी है वैसे ही vehicle भी clean होगा after the transportation with the 1% sodium hypochlorite solution. At the crematorium or the burial ground, what point should be kept in mind? The crematorium or burial staff should be sensitized that COVID-19 does not pose additional risk. The staff will practice standard precautions of hand hygiene, use of mask and gloves. Same, यहाँ पे भी same use करना है, यहाँ पे सिर्फ mask और gloves sufficient है. Viewing of dead bodies by unzipping the face and of the body back by the staff using standard precautions may be allowed for the relatives to see the body for the last time. कई बार relatives करते हैं कि last time body देखना चाहते हैं तो we should always allow. अगर किसी भी चीज में ब्रीच नहीं हो रहे हैं आपके प्रोटोकॉल्स तो आप बिल्कुल अलाउ करें, पर स्टाफ अनजिप करेगा फेस हैंड से by using the standard precautions. All the religious rituals like reading the religious scripts, कुछ पढ़ना है, कुछ sprinkling holy water है, कुछ भी last rites हैं, that does not require touching of the body should be allowed. But bathing, kissing, hugging of dead body should not be allowed. Large gathering at the crematorium should not be allowed because जो उसके family members हैं, your relatives हैं, can be a potential source of infection. They can be asymptomatic carriers, or they be the source of shedding. They may be shedding the viruses. So we should avoid large gathering at the crematorium or the burial ground. We should prefer electric or gas crematorium, which eliminate the chances of infection. The funeral or the burial staff and the family members should perform the hand hygiene after cremation and burial. Cremation is recommended either by the electric or gas, and burial depending upon the religious sentiments. तो ये guidelines में कुछ नहीं है कि आपको burial prefer करना है या cremate करना है body को, तो it depends upon the religious belief of the patient. Burial, but कुछ point है कि burial should be done in a thick airtight coffin placed at the depth of 4 to 6 feet. थोड़ा depth बढ़ा दिए तो थोड़ा depth में 4 to 6 feet की depth रखना है और airtight coffin use होगा. Area above and adjacent to the grave should be cemented immediately as an additional precautionary measures. ये भी थोड़ा सा है कि सारा आसपास cemented area कर देना है. The area should be marked and the ashes अगर crematorium हुआ है तो ashes does not poses any risk and can be collected to perform the last rite. All my slides are based on the guidelines of dead body management from the Ministry of Health and Family Welfare. If one can go through the whole guidelines, and these are the references for the additional studies. Skills to be enhanced, वही 3 बात जो हमने स्टार्टिंग में करी थी और हमें ये प्रैक्टिस में लाना है और बहुत ही इंपॉर्टेंट है हम लोगों के लिए, हमारे लिए, हमारे स्टाफ की सेफ्टी के लिए. These are hand hygiene, use of PPE, and appropriate disinfection. My sincere thanks to all the contributors and my sincere thanks to Sarika ma'am and Dr. Chandrakanta ma'am. Thank you, ma'am. Sincere thanks to all the listeners.
Thank you, Dr. Anupma, for elaborating in so simple language about the care of the disease. So this was the last presentation for today. So we will we'll meet tomorrow for tomorrow topics. So thank you all. Thank you.
Thank you, ma'am.
So I should end right now. So any question, anyone? No questions. So it is the last. So thank you all.
Thank you, ma'am.
Thank you, Dr. Rahman.
Thank you, ma'am.